Okay, Jan Belolavec. So there was a change just now. So you will not do the introduction. It will be Antonella Degani who will do the introduction. So
Perfect.
I invite you to stay here, but I think everything will take place on site. But yeah, I just heard that it was someone else. Sorry for that.
Okay, no
And
problem.
yeah,
Okay, so I'm online. I'll close my video and I mute myself
yes,
and wait for
perfect.
my instructions.
Thank you very much. Thank you.
Good morning. Yeah. Good morning, everyone, and welcome to the 21st ECoPEaT meeting, which is a special meeting this year, especially post-COVID, the first perfusion conference, I think, in the last 1 year and a half. So I'm very happy to see you all here. It's also a very special meeting because it's our 30th anniversary. I am Corneel van der Wielen. I'm this year's conference organizer. So if you have any problem, please, you can come to me, come to the technical staff, or somebody else of EBCP, and we will help you out. To start with, I would like to introduce the chairman of the European Board of Cardiovascular Perfusion, Professor De Zomer, and he's going to give us some welcome address.
Good morning, ladies and gentlemen, dear colleagues. First of all, I would like to welcome you at this beautiful venue of Barcelona. I also would like to thank the local people, being Maite, for their warm hospitality and for arranging a lot of practical issues. But we are mainly looking forward to have, for the first time in more than almost 2 years' time, again a live meeting. And I think we are all very happy that we can do that, although today it's still in part live and in part virtual. Hopefully next year we can do it again 100% live. But I do hope that we will have some stimulating discussions here. I think the scientific committee has done a great job in gathering together some beautiful presentations. So I hope you will enjoy them. But I also would like to ask you one favor. As a courtesy to our speakers, as a courtesy to the audience, please put your mobiles on silent mode so there is no disturbance during the sessions. I'm looking forward to speak with all of you during the breaks, and I wish you a very successful convention. Thank you so much.
Thank you, Professor. So I would like to open the first session then. I would like to invite our session moderators, Professor Dr. Van den Briele, Antonella Degani, and also Professor De Sommer again. And Maite, as one of the organizers of the conference from Barcelona, she will be opening the conference with her talk about normothermic regional perfusion.
Thank you. Goedemorgen. Nice to meet you. Good morning, ladies and gentlemen, Mr. President, organizing committee. Thank you for giving me the opportunity to present our experience in... ¿dónde está la presentación? Sorry. Ven. ¡Ey! Ven. ¿Que cómo lo hago? Porque no se ve. Ahora. Gracias. Sorry. I'm not an expert in informatics, in computers. As I say, thank you for the opportunity to present our experience in donation after circulatory death. Donors after circulatory death have shown a potential source of transplantable organs. Spain has a long history and experience in organ donation. In my hospital, uncontrolled donation after circulatory death, Maastricht 2, began in 1986. Not was until 2014 that we started with controlled donation after circulatory death, Maastricht 3. All procedures were carried out by physicians of the procurement department unit. Perfusionists act as advisors for technical management problems that could be appear. Let me show the difference from UDCD and controlled DCD. After cardiac arrest, without possibilities of resuscitation, a mechanical compressor is placed and patient is transferred to the hospital only for donation purposes. At the arrival, the patient is declared dead and connected to an ECMO for organ preservation. When a withdrawal life-sustaining treatment is indicated, the organ donation after circulatory death is possible using an ECMO support during premortem or postmortem cannulation. Depends on the protocol of every center. We can do it in ICU unit or in OR, operating theaters. We maintain ECMO for 1 hour until we start organ procurement. You can see how is the evolution in donation after circulatory death in Spain in the last 20 years. Controlled DCD has increased very significantly in the last 5 years, while uncontrolled Maastricht 2 DCD remained stable for all this period. In this slide, you can see the cause of death of the donors, and is as follows: head trauma, anoxic encephalopathy, and arterial cerebral stroke. Anoxic and arterial cerebral stroke is also one of the etiologies of the Maastricht 3. As a curiosity, I want to show you the mean age for both CDC and UDCD donors and the sex distribution. The perfusion unit started to collaborate as active members of the donor team in June 2018. That was possible due to an increase of the number of perfusionists and a better organization of the unit. Actually, our unit has 9 perfusionists, I'm included, that should cover 4 on-call 30 days a month. When the perfusion unit is activated for DCD, if the procedure is inside our hospital, one perfusionist attends. If the procedure is outside the hospital, that means an hospital from the area of Barcelona or the Catalunya, 2 perfusionists attend. Just a brief summary of the supplies and the equipment that we use for both procedures, DCD and controlled and uncontrolled DCD. Here is the circuit and femoral cannulation in all patients. As you can see in the circuit, you can look at the connector post-membrane that is used for the administration of the preservation solutions at the moment of the organ procurement and when the ECMO is stopping. Also, I want to show you the catheter that is placed to occlude the thoracic aorta before starting ECMO support. As it is written in our protocol, we have to take some blood samples during the perfusion for testing the efficiency of the perfusion and the availability of the organs. As I said, the perfusion unit started collaborating with the transplant unit in June 2018. Since with performing all UDCD and CDC with ECMO support. Since June until December 2020, we have participated in a total of 77 Maastricht 2 and 29 Maastricht 3. 77 Maastricht 3 and 29 Maastricht 2. 14 of these CDC were in our hospital, in hospital clinic, and 63 of our donors, especially for liver procurement, were in other centers. 52 of our donors were valid for liver, 86 for kidney, 8 due to the kidney count twice, and 8 lungs and 3 pancreas. 24 were discharged for several problems: cannulation, aortic dissection, increased liver enzymes, or no valid organs after laparotomy. Results. Trying to find some differences that support the inclusion of the perfusionist in the transplant procurement unit, we made an approach and a first statistical analysis. CDC results, Maastricht 3. In this slide, you can see a description of a sample description in terms of age, BMI, ICU stay, functional warm ischemic time, total warm ischemic time, and ECMO period. We compare the perfusionist group since 2018 and previous group. That means the physicians of the procurement unit before 2018. This is some other things that, as a curiosity, that we found, the comorbidities that had our donor patients. And we have seen in this previous statistical analysis that the renal transplantation rate in Maastricht 3 was similar in both periods for both groups. Liver transplant rate in Maastricht 3 tend to improve from 61 to 62, even is not significant, and we think that this is due to the perfusion group. The number of the samples of the perfusion group is at the moment small. And we find that similar results in terms of recovery and discharged the transplanted patients with ECMO support by the perfusionists and the previous group, the physicians. For Maastricht 2, this is the description of the sample in terms of age, BMI, initial circulatory arrest without a total warm ischemic time and ECMO period. As you can see, as a curiosity, the perfusion group has less ECMO period than physician. This was because at the beginnings, when the physicians were responsible for the donation after circulatory death, they has to do a lot of things during the procedure: run the pump, talk with the family, order the samples, organize the operating theater, and this, we think that this was the cause that the ECMO period was longer than perfusion group. Renal transplantation rate in Maastricht 2 improved from 62 to 74. Liver transplant rate in Maastricht 2 changed, and we changed from 93 for the physicians groups to 3.4 for perfusionist group, and we think that these changes is In conclusion, the inclusion of perfusionists in our center has marked a turning point in donation. Perfusionists perfuse different. A deceased patient, but organs must be kept alive to increase life expectancy of our patients that are waiting for an organ. In donation after circulatory death, our participation allows a more efficient organization of the procedure. In uncontrolled DCD, warm ischemia is severe. The experience and skills of the perfusionist is essential to maximize organ preservation and procurement. Procurement and transplantation rates are similar in both groups and trend to be better. The incorporation of the perfusion unit to the transplant procurement team could mean greater efficiency and better organ recovery with better implant results and a shorter ICU stay of the transplanted patients. We are very concerned that further analysis should be performed due to our sample was small. Thank you very much. I hope you can understand my English, and I'm really happy to see you again here after this so bad period that we have passed. Thank you very much.
For this very nice presentation. We will first listen to the first three presentations, and the next one will now be introduced.
Okay, I am very glad to introduce the next speaker, myocardial protection in 2021 is Mr. Dr. Günaydin of Turkey. I'm very pleasure to introduce you.
Hello. Good morning. It's very nice to be back here. As you know, it's been a difficult 2 years for us. So my wife was always complaining from my carbon footprint flying all over the world. Now I don't have any carbons in my body, and I have 4 vaccines to come here. So it's very nice to be here again. So today I'm going to talk about our recent research on myocardial protection in the last 2-3 years. and try to discuss the alternatives now going on. Yep.
Can we have the slides, please?
Oh. Yeah. Okay. So we don't have any conflict of interest with the studies presented here. So this is our hospital. It's situated in Ankara. It's a brand new hospital. So we used to do about 4,000 open heart cases before COVID era, and now doing about 3,000 cases after COVID. We do any type of surgery, including CABG, conventional valve surgery, minimally invasive lung transplant, and heart-lung transplants. And ECMO, about 200 cases a year. So as you know, when you check the literature and write down cardioplegia or myocardial protection, you can see hundreds and thousands of papers until now, but mostly usually on adult. And when you check for the myocardial protection in details, you see a lot of papers on blood cardioplegia in the literature, and then going down to microplegia and HTK, Danido, and the others. So it's always a very popular topic, and now it's turned out to be, in the last 3-4 years, to use of single-dose techniques. So we started with the Danido solution. As you know, it's a conventional formula, is like that, but nobody probably is using the conventional formula right now. So according to the latest reports in US, there are more than 350 different formulas, all of them calling themselves Danido. So when we are talking about Danido, we are not sure what we are talking about, but theoretically, it has a lidocaine, and it's the molecule who does all the effects or impact of the solution for the long-term support. So it theoretically reduces the energy consumption, preserves high-energy phosphate, but of course, its single dose have always the same problem, doesn't keep the heart very much cold. So it was originally designed for pediatric use, and lidocaine dose is very important. It's always underlined by Danido himself. Especially in the repetitive doses, you should really consider the dosing of the lidocaine in order to overcome any toxicity. So HTK is comparatively an older solution, first introduced for heart transplantation, and now it's also being used for adult cardiac surgery as a single-dose technique. So it has 3 different amino acids. As you know, histidine is the first important amino acid in the solution to protect for acidosis, and ketoglutarate for ATP production, and tryptophan for cell membrane stabilizer like lidocaine. So when we compare these 2 techniques with respect to the current literature, you don't see many different significant differences. So once for lidocaine dosing dilemma in Danido and sodium dilemma in the other solution. So there are always limited clinical parameters in adult conventional cardiac surgery. So we can see meta-analysis, and we have lots of literature just accumulating now. So for Danido, usually when you see a meta-analysis of both single-dose techniques, you always see non-inferiority cases. So they are okay for adult cardiac surgery, not inferior to St. Thomas or blood cardioplegia. And of course, the cross-clamp time is usually lower because you only give once a single dose. So this is, for example, more than 5,000 patients. And again, on reducing operative times because of the single dose, maybe sometimes requires less defibrillation and sometimes difference in cardiac enzymes, but usually they're all non-inferior studies. So blood cardioplegia is, when you compare them, this becomes much more clearer that even blood cardioplegia results are usually better than St. Thomas only crystallized solution. So they are comparable, but not superior to each of them. So we can even then go on to discuss, can you use those solutions in high-risk patients undergoing CABG surgery, for example? So this is a review article and says, no, they're not useful in high-risk cases. So literature has some different results and concerns of those techniques. So we don't have any comprehensive data to discuss in the clinic, especially in the late clinical outcomes. And when you check for the world, who are using which one, so it depends on where you are living, but of course, in Europe still, St. Thomason is the most popular solution, blood cardioplegia, and then the single-dose techniques. But in US, in CABG surgeries, 4-to-1 is the most popular one, and microplegia. In minimally invasive cases, usually single-dose are much more popular, but in urgent cases, HDK is the most popular one, according to this paper. So we started with this to our research, and we started to understand which single dose to use on which kind of patients as a proposal, and we started the research, we presented here, and we published this paper last year in 2020. So it was based on a cell culture model as a two-dimensional model. So we received 3 different cell lines, pediatric cell lines, adult cardiac cell lines, and myocardial cell lines. So we put them in the valves, and we tried to create like heart-lung machine and the impact of the solution on the cells. So we did a lot of testing, staining to understand the viability of the cells and how long those cells were viable, and the toxicity of the solutions. As you know, we have some concerns on lidocaine and sodium doses. So here are the results. When you check for the myocardium itself, in the early period, really there is not any significant difference. The difference becomes after 24 hours in the long term. And this is adult endothelial cell lines, again, in the early period, not significant difference, but becoming some kind of differences in the long term for single-dose techniques. And for neonatal cells, pediatric use, not any difference in the early period, but single-dose becomes much more prominent in the long term. These are the stainings, so green cells are viable, red cells are dead. As you can see, so HDK really takes control very well. Dalnido becomes a bit problematic in the long term after 24 hours. St. Thomas doesn't work after 24 hours, and blood is also very good in the long term. And for adult cardiac cells and pediatric cardiac cells, as you see, St. Thomas and blood fails in the long term in 48 hours. And this is the toxicity. They don't have any toxicity on the cells, even in these current doses. So as a conclusion, we just started with the cell lines. We tried to understand, so for pediatric cases, pediatric cell lines, they work fine, but in the adult, they have still problems. And then in the second question comes, how about the long-term protection? Again, we organized the study, we published this in 2021 in the Asian Annals. So, and now we have 3 different groups, Dalnido group, HDK group, and blood cardioplegia group. They are the most popular 3 of them we are using in our current practice. They are all dosed with the conventional dosing, of course. We also try to understand the glycocalyx breakdown in those patients. Very briefly, as you know, glycocalyx is a membrane covering the endothelial cells. It's supposed to be the earliest prognostic value to show us there's something wrong with the cellular protection. So our aim was to understand the long-term follow-up of those patients according to cardioplegic techniques. So we just put some iPhone-like machine on the patients, you can see here. And then it was documented 24/7 for ECG, blood pressure, and anything. And then it was just followed up by a call center. So there's a button. When patient feels uncomfortable, he presses or she presses on the button, and then this call center calls us. So there were follow-up like this for 1 month, and to understand the impact of the only difference in between those patients are the cardioplegic solutions. So about hundreds of patients in each group before surgery, they were all comparable. And in the long term, this is also the hospital value. So especially in the Dalnido group, the interleukin levels were higher in the operating time with the heart-lung machine. Significant levels shows us the glycocalyx degradation. So it was also significantly higher for Dalnido. That means the cellular breakdown is a bit larger. So this is the result of the perioperative period, not anything difference in the early period, only the dose of blood cardioplegia, of course, in giving every 20 minutes. And these are the results of the long term. So the Alnido group has significantly more atrial fibrillation, arrhythmia problem, and significantly more rehospitalization rate within 1 month. Of course, the numbers are not high, only 55, 60 is the long term, but it gives us something. So we need to have a problem with the arrhythmia in those patients, and of course, according to the rehospitalization. This is a graphical demonstration. They were documented to have more tachycardia and AFib. So as a conclusion, in the long term, maybe the Alnido may have some problem. This was designed to protect only 90 minutes. So 90 minutes may be long for the Alnido single dose. So then the next question, how about the hemodilution? So you give 1.5 liters or 2 liters of cardioplegia at one time. So we also presented them 2 years ago. So we compared 4 different groups this time about hemodilutional effect. Again, in the same conventional proposed doses, about 1.5 or 2 liters at single time. So the primary endpoint was the transfusion rate, and the secondary endpoint was the hematocrit change. But our protocol is to use ultrafiltration for any single dose technique. So we use ultrafiltration until reaching the target hematocrit of 25%. So if you use, and this is the early postoperative follow-up, not many significant differences. So hematocrit levels were like this if you use ultrafiltration at the end of cardiopulmonary bypass. So we always use, if you use single-dose techniques in CABG surgery, we always use ultrafiltration at the end of surgery. If you use, of course, 1.5 or 2 liters. Plus, we always put some vent during the infusion to take all those overvolume out. And then, how about redosing? So we then published this report again this year in minimally invasive aortic valve surgery to compare the effect of redosing of Alnido and HTK. So this time 2 groups only, 100 each. And if they are redosed, they are all additional 2 subgroups. So this is the patient protocol. This time, we also worked the aquaporin levels. Aquaporins are the very important elements inside the cell to carry on the excessive volume outside the cell. So when the cell is exposed to high volumes, so they start to produce aquaporins to overcome those volume overload. And if the excessive volume is very much high, the cells fail to produce aquaporins. So this time we also studied the aquaporin levels of those cells in the groups. So this is preoperative comparison, no difference. And this is the postoperative comparison. So again, in the AFib incidence was higher in the Alnido group for 190 minutes, of course, especially in additional dose. So in the first 2 comparison, you see not anything different. But in the redosing group, so if you give the Alnido with the same lidocaine dose, in the second time, you may have some problems. So you should be careful about the lidocaine doses. So this is the repeated doses makes the Alnido group much more inflammatory response. Again, some glycocalyx degradation is a very early marker of the cell injury. And aquaporin levels were significantly lower in the Alnido group because of the cell edema. They cannot handle the excessive volume. You see the microscopic levels of the cells from the heart. So Alnido, you can see the glycocalyx is much more brighter on the right-hand side. Bright means bad because the cell is broken. Glycocalyx comes out and you can stain, and so it becomes bright. And this is the aquaporin level. As you see, the Alnido group has some more edematous cells with respect to the HTK group. So as a conclusion, you should really consider giving the Alnido for 90 minutes. It's maybe too long. And also redosing is much more important, especially for the Alnido group. So then how long is not too long? And then how about the hot shot, reperfusion? So the questions always arises again. And it should be used for all adults or some of them, or which one? So then we just produced a new study that I'm going to present here in the AX meeting. So this time we have 3 different groups, but we just prepared a specific solution to overcome the volume overload or redosing. So we only chose some kind of surgery that we expect the cross-clamp time to be shorter than 1 hour, like CABG +3, CABG +4, CABG +2 sometimes. So surgeon arranged these, for example, if you are finishing the distal anastomosis and it's around 1 o'clock, 1 hour, so you should stop and you should do the proximal anastomosis on beating heart. Or if you have time, you should wait you can go up to 1 hour. So we arranged by the surgeon like this to have only 1 hour cross-clamp time or around 1 hour, but we halved the doses. So here, the Dalnido dose was 1 liter, HTK dose was 1 liter, and blood cardioplegia dose was a conventional dose. So our aim was to check if, for example, 1.5 liter or 2 liter is okay for 1.5 hours or 2 hours. How about half dose for 1 hour? That helps us to overcome 75–80% of all operations. So the methods were very much same, and of course routinely for CABG surgery we use retrograde cannulation, and as I've told you, ultrafiltration and plus the sump venting from the LA. And this is the preoperative evaluation, not anything different. And then we just did a very good, we have very good results. We just controlled 92% of all patients we targeted by 1 liter for 1 hour dose. So why did we do that? So we tried to overcome hemodilution effect of 2 liters. We don't use LA venting for 1 liter. We don't use ultrafiltration this time. We don't have any case of sodium imbalance for HTK, and we don't have any lidocaine toxicity for Dalnido group or arrhythmia. So this helped us to completely solve most of the problems. So I'm just finishing because of the time. So when we are dealing with single-dose techniques, it's very important to control temperature and pressure. It's one of the most important and usually underrated points in using cardioplegia. So we use retrograde for CABG, venting, ultrafiltration. So I have told all those. So Dalnido has some problems because of the 300 formulations and more. So when we are talking about Dalnido, so what is Dalnido? If it's a conventional dose, it's 2 liters or 1.5 liter, 90 minutes, 60 minutes, 2 hours, which one? So redosing is always a problem for any of the solutions here. So that should be very carefully studied. So in my case, I do, if I have a simple case, I never have any more. Good left ventricular function, cross-clamp time expected to be lower than 1 hour. I can use blood cardioplegia or single-dose techniques of 1 liter. Simple cases, poor left ventricular function, cross-clamp time supposed to be less than 1 hour. I can use blood or HTK, 1 liter. Combined cases, good left ventricular function, cross-clamp time more than 1 hour. I try to use, if I use Dalnido, I need to redose it in every 60 minutes. So I use 1.5 liter Dalnido for 60 minutes. HTK, again, 1.5 liter. I can go up to maybe 1.5 hour with HTK. So emergency cases, minimally invasive cases, I usually use HTK 1.5 liter. Or if it's less than 60, I can go up to 1 liter only. So in the COVID era, we have much problems dealing with, and also cardioplegic solutions are also very important. So I need to also talk about some safety projects. So we are working on the new version of Custodial N on cellular lines. So my colleague just presented DCD before, so we are dealing with mitochondrial transplantation in liver and kidney cases. So we now try to understand the mitochondrial impact of DCD patients in liver transplants. So this is another study ongoing. And we compared NRP or hypothermic oxygenated perfusion in these liver patients to see the difference, which one is protecting better or not. And we are working on nanoparticles to concentrate all those single-dose techniques, so less than 20 milliliters. So if we can succeed this, we can only give 20 milliliters. And on the heart, when it becomes 34, these nanoparticles will dissolve to make it 1 liter in the heart. So there are ongoing studies. So myocardial protection is a concept without clear and specific clinical science. Every day, new publications, especially for single-dose techniques, but still not definitive results, not very class 1 or A evidence yet. So we should study more and more to understand the clear impact of those solutions on the heart, especially in the long-term protection. Thank you very much.
Okay, thank you very much. Next is my great pleasure inviting Dr. Federico Pappalardo from Italy to the stage, and he will talk about hemoabsorption per and post cardiac surgery, and will give us a 2021 update. Thank you very much.
Okay, does it work? Okay, so good morning everyone, and thank you for inviting me. I'm happy to join this community today back in presence. The motto of this meeting is celebrating milestones, but it looks like to me when I looked at the program that you are celebrating the next future of extracorporeal circulation and how that can be nowadays a platform for delivering special therapies in complex scenarios. In this regard, I have the pleasure to discuss about the value of hemoabsorption in cardiac surgery in the current era. So just for those of you who are not familiar with the CytoSorb cartridge and the CytoSorb concept, it's a cartridge which is made of polymerous beads, and these beads work as sponges that can absorb molecules. The concept on the basis of physical properties, it's driven by the fact that this is a significantly large adsorption surface, which is about 45,000 square meters. There are some physical characteristics of these molecules which can be absorbed, which have to be hydrophobic and in a certain range of molecular weight, and we will discuss this later. And the process of adsorption is concentration dependent, and this is very important in terms of expected results and therefore timing of application and safety of the concept. So when we discuss about size and selectivity, it's important to remind that key factors such as albumin, coagulation factors, and immunoglobulins are not removed by the device. The concept of concentration dependency is important because, of course, you can discuss about efficiency, and efficiency is very much dependent on the value of the baseline molecule when the therapy started. So the higher the value, the more efficient the device, but we have to question whether we have to wait for such high levels of toxic molecules for having an efficient process. And the other concept is about coagulation, because this extracorporeal therapy is safe in terms of activation of coagulation and consumption of platelets. Indeed, I will discuss how anticoagulation protocols should be managed in this regard. So, which substances are removed? I think that there are a couple of key elements that we will discuss. Inflammatory mediators, so all the molecules which are activated by an inflammatory process, either infectious or sterile process of inflammation. There are some molecules which are metabolites, such as myoglobin, bilirubin, and free hemoglobin. And this device is also able to remove some drugs. And this is a new attractive perspective in the field of cardiac surgery. So why cardiac surgery is so important in this regard, and why is CytoSorb valuable in the cardiac surgical population? First of all, because we discussed about inflammation, and cardiac surgery is a model of mixed inflammation, which means that we have this eventually infectious inflammation in case of endocarditis and patients with ongoing infection. But cardiac surgery itself with the surgical trauma and extracorporeal circulation is a model of sterile inflammation due to artificial surfaces and different mechanisms. On top of that, we have to remind that we are currently facing new populations, and these populations are contemporary patients who have multiple drugs on board, who have received multiple percutaneous treatments, and who have modern drugs, therapies such as novel anticoagulants and novel antiplatelets. And there is still room for emergency cases in this population. And of course, if you are being operated with such drugs, you have a higher risk of bleeding. And you know that ticagrelor is the standard of care for patients who have acute coronary syndromes nowadays, either undergoing or not a PCI procedure. And the use of novel anticoagulants for the treatment of non-valvular atrial fibrillation and other related thromboembolic scenarios is significantly increasing. Therefore, we have to face these challenges, and it's very attractive that we can proceed eventually for an emergency operation with the potential of removing these drugs via an adsorption concept. These are the features of the device in terms of how to set up in the extracorporeal circulation machine. And generally speaking, I think that, I think that there are also post-operative scenarios that warrant consideration for this concept, because we can have patients who have severe post-cardiopulmonary bypass inflammatory reaction syndrome, which can be on the clinical grounds called vasoplegic shock, can have what is called septic shock and require extracorporeal support with ECMO. And it's important to remind that the tolerance of the patient to adverse events is very much driven by the preoperative comorbidities. So our sensitivity to how much we can tolerate and what is the trigger for intervention is should be currently driven also by the baseline comorbidities in terms of liver and kidney function. In terms of practicalities, this is how we can eventually put the therapy in the extracorporeal setup of the patient. Either the patient is on ECMO, either the patient is receiving CVVH, either as a standalone. And you currently know that there is also the opportunity to run these circuits all together in an ECMO setup. When we go into the, let's say, challenges of scientific evidence and the proof of concept, it's very important to discuss what is this. So now we have to remind that this is an adjunctive therapy. And it's very important to recall that patients will need the primary disorder therapy in terms of adequate surgical strategy, antibiotic therapy. So this is something that we are putting in place to improve the results, but this is not something magic if we fail to approach the primary disorder with these standardized and appropriate therapies. So the concept of proof of evidence is very important as we discuss about an adjunct and not a therapy itself. And I think that besides all the molecular aspects and biological aspects and proof of evidence in terms of efficiency when we dose molecules in the blood, I will try to recall you that we are on the clinical ground, and there is consistent evidence that the amount of inotropes and hemodynamic stability is one of the key factors and a sort of fil rouge across all the experiences and published papers in the field of cytosorb therapy. So I think that we have to focus on the value of therapy in terms of reducing the amount of inotropes and providing hemodynamic stabilization in this regard. And we know that decreasing the amount of inotropes is one of the key factors for the contemporary management of critically ill patients. This is a series of papers which have been published across the literature and can show you that in this paper from Germany in patients with septic shock, again, there is evidence of reduction of inotropes. We have published a couple of years ago when I was in Milan a series of patients who were extremely sick with expected mortality rates according to the SOFA score in the range of 80%. Most of them were on ECMO with cardiac arrest. And we were in the early phase when we used to wait for higher values of toxic molecules to be clinically relevant to start the therapy, yet we had the opportunity to significantly decrease the mortality as compared to what was expected with the SOFA score. And similar results have been published again from groups from Germany in terms of use of cytosorb to treat the inflammatory response after cardiac surgery, and also after cardiac surgery for endocarditis, which is one of the most, I would say, new challenges as we are, I think, all experiencing a surge of patients with endocarditis, and these are very challenging cases. On top of that, ECMO is exploding, is booming. And I do believe that besides the value of ECMO in terms of providing extracorporeal support, we do have to acknowledge that the therapy is somehow producing a secondary insult to the patient in terms of increasing the amount of inflammation, eventually activating coagulation, producing some amount of limb ischemia. And last but not least, ECMO is provided in patients who have profound multi-organ failure, cardiogenic shock. So there is some accumulation of metabolites such as myoglobin, troponins, LDH, and bilirubin. So we have considered and given value to the preemptive application of cytosorb when patients are treated with ECMO, especially if ECMO is implanted for ECPR in the setting of cardiac arrest. And again, there are reports and case series in the literature that describe this potential application and give value in terms of reduction of inflammatory mediators and again on the reduction of amount of norepinephrine usage in this patient's population. Again, ECPR is definitely one of the most attractive fields because ischemia-reperfusion is a model of inflammatory disorder. And for those of you who have experience in ECPR, definitely this is very important. And as mentioned, whether you have also the perspective or in this scenario of uncontrolled DCD donation, you might give value of the potential of preserving organs for transplantation. I mentioned that at the beginning that there is a key role in terms of deciding what is the best timing for starting the therapy on the patient's comorbidities, because of course you can expect that the tolerance of some insults such as the increase of bilirubin or myoglobin is different according to the baseline renal function and liver function. And the liver is one of the most attractive fields nowadays because there is, in the field of acute liver failure, especially for patients who have acute and chronic liver failure and who are listed for urgent transplantation, they need to have a sort of artificial liver, which is one of the challenges in pathology. And we know that this process is complex, and patients sometimes are stopped or suspended on the waiting list because acute on chronic is precipitated by infection, and infection is a contraindication for emergency liver transplantation. So you might eventually benefit from the potential of mitigating the failure in terms of metabolic derangement of the liver, but also in mitigating the inflammatory response, which is driven by infection in this regard. And bilirubin is clearly effectively removed. Again, these are data available in the literature on effectiveness. And myoglobin in the setting of rhabdomyolysis is, again, similarly effectively removed, and that has a key factor and key role in preserving the kidneys in this regard, either with CVVH or as a standalone therapy. So again, I think that the decision process is complex nowadays. We have been challenged by the requests for how to use and on which basis to use this therapy. But I think it's very important to recognize that we have to understand when to start, but also to identify the patients who are non-responders, because of course there is a subgroup of patients who might be non-responder. And again, just to go on basic clinical grounds, I remind you that the failure to reduce the dose of inotropes and to gain hemodynamic stabilization might be an easy tool to identify the patients who are not responding. So at the end, I think that we have the question in whom, when, and how after cardiac surgery. So in whom, these are the population, and again, systemic inflammatory reaction syndrome, infective endocarditis with septic and cardiogenic shock, patients who need inotropes at a high dosage, hyperbilirubinemia and hypermyoglobinemia. When, again, please use specific primary therapy to fix the primary disorder. If this therapy fails and the patients are defined refractory in a time frame which can be in between 6 and 24 hours, consider the adjunct of cytosorb, especially if you have some key elements such as the vasoactive inotropic score higher than 30, if you have high levels of interleukin-6, and you have poor lactates clearance. And how? I think that this is a technicality that this community has no challenges to put in place, because you are able to consider the application in CPB, ECMO, standalone, and CVVH configuration. And I remind you that there is no significant change in terms of anticoagulation protocol, and in the flows which are expected to be on average, I would say 300 milliliters per minute. Thank you for your attention.
Thank you very much for this update on this relatively new therapy. We all know that organ protection and organ preservation is a keystone for having a good outcome in our patients. And as such, we can have now a discussion on the first 3 papers which were presented. So I would like to ask the 3 speakers to come forward. And if there are any questions from the audience, I'm sure they will be more than happy to answer them. Are there any questions?
I have the questions for Professor Pappalardo. Do you have an experience about the use of a hemofilter about heart transplantation? Because in our center, you use the hemofilter, but we have a different result in this case for the heart transplantation.
So heart transplantation is definitely a challenging operation, and in this regard, I think that can be considered one of the I would say default applications of the therapy without waiting for further complications. I think that it very much depends on how the patient is arriving to transplantation. I think that, no doubt that now transplantation is a complex operation because due to the shortage of organ, we are using organs which have a long ischemic time. There is also new applications of organ procurement. So I think that this can be one of the scenarios where I would use always the device. Last but not least, we have now patients who are receiving heart transplantation bridged on an LVAD, which makes definitely the biological inflammation more significant. And I have seen, to tell you the truth, that there are centers who bridge patients to transplant with novel anticoagulants, which I recommend not to do. But anyhow, if you have such patients and transplantation is per definition an emergency procedure, you can, if the patient is on rivaroxaban, you can remove rivaroxaban. I want also to mention that there are growing data or preliminary data also on other novel anticoagulants. Some reports describe the efficacy on the removal of dabigatran, but yet I think that we need more robust data to state that the dabigatran is removed by the cytosol.
Thank you.
There is a question over there.
Yes, I have a question for Ms. Mata. Maite, here I am. So congratulations on your presentation. It's very nice to see that you have a very large experience in NRP now. But I'm asking myself, the system you showed, it's like an ECMO system, I think. But
Yes.
wouldn't you reconsider using a reservoir to empty the heart during reperfusion? Because if the heart is empty, this would improve your myocardial perfusion, I think, no?
We don't have experience in the procurement of the hearts from the dead patients. We have not started in our hospital. Okay. So when we start the DCD as a perfusion unit, at the beginnings we use a reservoir. But that means that we have to use a little bit more prime, and we have had a lot of some kind of problems, and we prefer to change to a closed system, like it's the same system for an ECMO of the alive patients with some specific modifications. Yeah. When we have a protocol for starting with to procure hearts, and of course with hearts, if we have to take a heart from a dead patient, we need a reservoir, of course.
Okay. Thank you. Maybe just another question considering the NRP, but I think Professor Gunaydin would be willing to answer that. So suppose that we are procuring a heart with normothermic perfusion. How would you manage your oxygen level during reperfusion? Would you recommend starting hypoxic when reperfusing, or would you rather start hyperoxic or normoxic? What would be your opinion about that?
I can only talk about our results on the animal experiments that I showed here. So we are starting with the normothermic in those animals. So that was a bit better than starting with hypoxic or hyperoxic.
Yeah, better hypoxic, so that's what you mean. Okay, thank you.
Thank you.
There's one last question over there.
Thank you for a very interesting session and for 3 excellent talks about organ protection. I've got 2 questions. One for Professor Gunaydin. I'd be interested in your cell line in vitro results, and one of them showed, for example, that after 12 hours there's an effect, a negative effect by the St. Thomas cardioplegia solution. How do these results translate into the clinical practice and into the in vivo setting?
Thank you very much. So since these are the cell line studies, and there's of course 2D cell lines, there are of course many concerns on transferring this information completely to the clinical practice, but this was a kind of start for giving us let's say a visionary evidence for the effects of those solutions. So for example, for St. Thomas, the viability cannot go further. We just checked for the all solutions up to 48 hours. So starting from the 18 to 20 hours, St. Thomas protection level started to come down, and finally there was no protection. So maybe this gives a rough idea to say that St. Thomas may have a good protection within the early period, not a long time.
Thank you. And a question for Professor Pappalardo. You mentioned the indications for cytosorb, mainly in post-operative patients and septic patients, which was really comprehensive and interesting. What do you think about preemptive use of cytosorb intraoperatively in high-risk patients?
Yeah, I think it's very important to remind that, as discussed with Antonella Degani earlier, there are a couple of situations in which you can expect just from the beginning that the patient is going to have a high-risk surgery. This high risk I would divide on the basis of the priority of surgery, so emergency of procedures. In general are high-risk procedures because either you have a patient who has anticoagulants or antiplatelets on boards, either it's a complex surgery for aortic dissection or heart transplantation. So emergency per se is a criterion for being proactive in using this therapy. On top of that, there is the field of endocarditis, and any patient who has complex endocarditis with positive blood cultures and abscess, I think it should be considered for preemptive during CPB therapy.
Thank you.
Okay, introduce. Okay, thank you very much for the speakers. Very interesting session. I pleasure to introduce the next speakers. Is the magnetic levitation pump versus constrained vortex pump, a pilot study of the hemolysis effect during minimal invasive extracorporeal circulation. Dr. Condello, I'm very pleasure to introduce you.
Hi, good morning, everyone. It's a great pleasure for me to introduce the study about magnetic levitation pump versus constrained vortex pump, a pilot study on hemolysis effect during minimally invasive extracorporeal circulation. I come from Bari, Italy. I am a cardiovascular perfusionist, and my center is in TIA Hospital. This is my disclosure for this presentation. And minimize the risk of blood damage using minimal invasive extracorporeal technologies is critical, especially if patients show high hematocrits value during cardiopulmonary bypass. The recent generation constrained vortex pump with their inherent design improvement could lead to reduction in the red blood cell trauma. However, this topic is a source of potential bias, including the use of magnetic levitated pump. In particular, hemolysis and plasma-free hemoglobin release during extracorporeal circulation can occur from a number of patient-related and technical factors and might be worse with high flow or excess negative pressure within the circuit and the blood transfusion. Elevated plasma-free hemoglobin is associated with multi-organ injury, including severe acute kidney injuries. In this context, we present our pilot study on two different pump technologies, a magnetic levitation pump versus constrained, comparing 40 patients undergoing coronary arterial bypass grafting using minimal invasive extracorporeal circulation modular system. And we recruited 40 consecutive patients undergoing coronary arterial bypass graft. And in the study periods, the patients to be enrolled were selected on the basis of the number of magnetic levitation pump to be tested. A request was made for comparing them in a pilot study with the centrifugal pump normally used in our center. The study protocol was approved by the local ethics committee, and informed consent was obtained, and the patients with chronic kidney disease, diabetes mellitus, anemia, and individual risk were excluded. the decision to perform coronary arterial bypass grafting with MEAC was left to the cardiac surgeon in accordance with the perfusionist. And during these periods, 196 patients were performed and 156 were excluded based on the aforementioned exclusion criteria, and 40 patients consented to participate to this study. This is the picture of the two minimal invasive extracorporeal circulation. We use the same circuit and change only the technology of pump. Closest circuit is a design of Meactis Society. A shunted hard shell venous reservoir was used, and aortic route and pulmonary vent suction was managed in series with venous return. The reference value for management of venous drainage was the central venous pressure, maintaining using rapid heal or vasodilatator, or upon request of drainage by the surgeon, and using the Trendelenburg position for lower values. During this study, we collected the cardiac index, the index of oxygen delivery, the central venous pressure, the inlet pressure of centrifugal pump, the revolution of the pump, the pressure of arterial cannula, hematocrits, and hemoglobin. And after CPB procedure, we measured the parameter plasma-free hemoglobin after 10 minutes of cardiopulmonary bypass, the lactate dehydrogenase, the indirect bilirubin, postoperative creatinine, and the total red blood cell unit administered. This is the results. The two groups are similar in feature and characteristics, and we found that the patients reported a good oxygen delivery and a good cardiac index without cavitation during the procedure. Because the problem during minimal invasive extracorporeal circulation is the frequently cavitation. And the results of this study, we found that the plasma-free hemoglobin after 10 minutes of cardiopulmonary bypass is a statistically significant difference in the patients that use the constrained vortex pump, and with a correlation of an increase of red blood cell consumption in the after postoperative periods. In conclusion, our pilot study suggests that the use of magnetic ventilation pump can reduce the degree of hemolysis in patients undergoing coronary arterial bypass grafting. Through confirmation for larger studies required. It was demonstrated that free hemoglobin is not significantly increased by centrifugal pump. However, no study reported the difference between the levitation pump and the other centrifugal pump. The best of knowledge, this is the first study that using MEAC system subset. The promising results recorded may be the direction for further research on this topic. The major limitation of our study is that the small sample, and that is the reason for the study design. This is not a randomized study. Another limitation is the lack of haptoglobin measurement, and plasma-free and hemoglobin and the lactate dehydrogenases were used as a hemolytic index. However, this may support furthermore recent studies suggest to improve minimal invasive extracorporeal circulation system towards minimal biological invasiveness. The use of MEAC with a magnetic levitation pump and centrifugal pump, if confirm its ability
The lack of measurement of haptoglobin is a major limitation. And I would like to stress on that because, as you know, there are 3 types of haptoglobin, and depending on your patient, they will clear more or less free plasma hemoglobin. So seeing the very small group and the fact that this was not determined, I think we have to be very careful in making conclusions out of these small series.
Okay.
Thank you, Prof. Okay.
Are there any other questions?
Okay, so thank you very much. Next, it's my pleasure to introduce Dr. Bansal from the Nottingham University Hospital in the UK, and she will present her abstract on the selection of prime constituents for CPB in the UK and Ireland.
Good morning, everyone. My name is Navi, and I'm a perfusionist from Nottingham in the UK. And this is my first time here at a European conference, so thank you so much for having me here today. It's amazing to be able to be here and present for you in person. So I'm going to be presenting an abstract for you today, and this was a study that I did last year as part of my final year of training in perfusion. And I looked at the selection of prime constituents that are used for adult cardiopulmonary bypass across the UK and Ireland. So just a little bit of background, there are around 60 cardiac surgery units across the UK and Ireland, and on average we are doing approximately 34,000 cardiac surgery procedures every year. So this average was taken over a 3-year period from 2016 to 2019. So of course over the last couple of years this is probably significantly less. And currently, there are no UK guidelines concerning priming in the UK. So the Society of Clinical Perfusionists of Great Britain and Ireland have a published set of minimum standards for adult cardiopulmonary bypass, but they don't mention anything about priming. However, the European guidelines for cardiopulmonary bypass in adult cardiac surgery state that different types and combinations of crystalloid and colloid solutions have been used, and they are often influenced by local tradition, and that there is no consensus regarding an optimal priming solution. So I think looking back on the history of priming, we can definitely appreciate how far we have come in terms of priming. So back in the early 1960s, priming was carried out using fresh heparinized homologous blood. Often up to 3 to 5 litres was used routinely to prime bypass circuits. So this was generally collected on the morning of the procedure, and this was then eventually transitioned to being collected the afternoon before a procedure was supposed to be carried out. So this produced a huge strain upon blood banks to be able to provide this amount of blood for priming these bypass circuits. And of course, using a solely blood-based prime was not ideal because it caused delays for emergencies, it was expensive, and it caused adverse physiological changes which were attributed to the large amounts of homologous blood use. This then prompted the exploration of an alternative priming method using varying degrees of hemodilution. And using an asanguineous prime meant that patients were not exposed to the risks associated with blood primes, and it also helped to improve the logistics of being able to run a very active cardiac centre where emergency procedures could easily be performed. So in terms of my study background, 2 previous studies have been carried out looking at primes across the UK and Ireland. One was carried out in 1994, and the last one was carried out in 2002. So I wanted to see if the trends have actually changed since those studies were carried out. And at our own centre, we had been using our prime for many, many years, and we wanted to evaluate our own prime constituents as well. So I wanted to create a summary of pump priming preferences and how they've evolved, and also consider the rationale for pump priming practices across the UK and Ireland. And my hypothesis was that there would be no consensus regarding priming constituent preferences. So for my methods, I originally developed a survey of around 15 to 20 questions, and I distributed this amongst my colleagues at the Trent Cardiac Centre in Nottingham just to get some feedback from them as to how I could improve the survey. So I wanted to make it as concise as possible while still being able to extract all the relevant information that I needed to create this summary. So I then ended up with a final survey of 10 questions. I was collecting primarily descriptive data, and this was distributed very kindly by Valerie from the Society of Clinical Perfusion Scientists of Great Britain and Ireland. And originally I was going to distribute this amongst all perfusionists to kind of improve my chances of getting more responses, but I quickly realised this was not a very good idea because I would end up with far too many duplicate responses. So in the end, I decided to distribute this amongst chief perfusionists only, and I also excluded any paediatric primes just due to their complexity. In terms of my responses, I had 32 responses in total out of a possible 52. And my survey was actually sent out twice, and it was left open over a 1.5 month period. So it was sent out once in March, and it was sent out again in April. And this yielded 5 duplicate responses. So I was then left with 27 eligible responses. 21 were from England, 1 was from Scotland, 1 from Wales, and 4 from Ireland. So to summarise my key findings and results, 69% of the respondents are using Hartmann's, and 31% of respondents are using Plasmolite, and nobody responded to say that they are using saline or ringers anymore. In terms of the use of colloids, 55% of the centres said that they are not using a colloid component routinely in their priming practice, and 45% of centres said that they are using some form of gelatin, whether this is Gelafusin or Volplex, Isoplex. Not everybody stated which gelatin they are actually using routinely. Nobody said that they are using starches anymore. And then 14% of the respondents said that they are using albumin occasionally. This was perhaps for transplant procedures or surgical preference and anaesthetic preference. In terms of additives, I was not surprised at all that 100% of the respondents are using heparin. The next most commonly used additive was mannitol, so 62% of respondents are using mannitol, followed by 15% using magnesium and 12% using sodium bicarb. And then tranexamic acid, a protein, and blood were also added, but these were only added occasionally according to, say, surgical procedure, for redo operations and things like that. So looking at the rationale, 39% of the centres said that their priming protocols were based upon historical use. So this is just what they've always used and they just haven't changed it. 29% of the centres said that their primes were based upon evidence only, and 32% of the respondents said that their protocols are based on a combination of both. So this is what they've always used, but it is also based upon scientific evidence. Just some other key findings and results from my survey. Over half of the respondents modified their prime according to patient-specific factors. So this included the exclusion of certain constituents due to a known allergy, for instance, a gelatin allergy, the addition of blood for patients with known anemia, and the addition of extra heparin if patients were over a certain weight. 7.4% of centres carried out some form of blood gas analysis on their prime. So they would take a sample of their prime and run it through the blood gas analyzer. They didn't state the reasons for doing this, but if I was to make a guess, I would say it's to make sure that the prime is physiologically balanced. And I noticed one of the centres also does paediatric cases, so I wonder if this is a practice they have adopted from their paediatric priming protocols. And 70% of the centres routinely use retrograde autologous priming. So this is a comparison of my results and the other 2 surveys that I mentioned previously that looked at primes across the UK and Ireland. So there has been a slight shift in the use of different prime constituents. So the use of Hartmann's has always sort of remained pretty much the same, around the 70 to 80% marks. The majority are using Hartmann's. 31% are now using Plasmolite compared to 7% who were using them in 2002 and 1994. And nobody is using saline and ringers anymore, so the preference appears to be for the more balanced crystalloids. In terms of colloids use, again, it hasn't changed much, but it's the specific colloids that have sort of changed. So the study that was done in 1994 stated that 44% of the respondents are using a synthetic colloid, but it didn't actually specify which synthetic colloids these were. In 2002, 57% of centres were using a colloid, so around, I think, 44 to 45% were using either gelafusin or Hemocell, and 12% of the centres were using starches. Now, I found that any respondents who were using a colloid component in their prime were all using gelatins, and of course the 14% of centres who are using albumin occasionally. So the shift has been towards using gelatins and has kind of moved away from using starches. So no study is without its limitations, and I identified two main ones. So number one, did COVID-19 hinder my response rate? So my survey was sent out in March and April last year, right when the UK went into lockdown and cardiac centres were not doing cases. So I don't think answering my survey was probably at the top of anybody's priority list at the time. So I wonder if I sent it out at a different time, if I would have had more responses. And I did also look at priming volumes in my survey. Now, not everybody reported their priming volumes. So from the ones I had, I worked out an average of about 1.4 litres. But there are numerous factors which can affect the reported priming volumes. So I did ask in my survey for everybody to answer questions in regards to their standard adult circuits that they use. But of course, different circuits will have different priming volumes, and I didn't ask which ones they use. So just to conclude, I think we're yet to reach a clear consensus regarding priming solutions and what constitutes an optimal prime, if there is one at all. And this may be attributed to a variety of factors, including the variability of the evidence and also a wide variation of patient-specific factors, which I think makes it quite difficult to produce a one-size-fits-all prime composition. And previous studies have suggested that priming solutions were considered relatively unimportant, and has this view changed? So the study that was done in 2002 found that 1/4 of the respondents considered their prime to be suboptimal, and that they would like to make some changes, whether this is adding an albumin, changing the volume of the prime, changing the solutions that they're using. I asked my respondents if they have changed their prime at all in the last decade, and 63% of the respondents said that they have actually changed something in their priming protocols within the last 10 years, whether this was solutions that they were using, the volume of the prime, or additives being put in or taken out. So I think this does sort of highlight a proactive approach to optimizing this element of bypass. These are my references, and I just want to say thank you to the University of Bristol, who supported me whilst I was doing this study, the European Board for having me here today. It's been a pleasure to come and present here, and I can't forget my wonderful team at the Trent Cardiac Centre in Nottingham. They have been incredibly supportive over the last 3 years that I've been there, and I consider myself very lucky to be part of such a wonderful team, so thank you to them. Thank you very much.
Thank you very much for your presentation. I have one small question. When you look to the two most used crystalloid solutions, being Hartmann's and Plasmalite, did you find any correlation between those and some of the products which were added to the prime, for example, bicarbonate? Because I could imagine that maybe people using Plasmalite would use less bicarbonate than people using Hartmann, or didn't you look for that?
I didn't really notice a difference, to be honest. Same with the colloids. I didn't notice, majority of people are using Hartmann's, but I didn't notice that respondents who are using gelatins are using them more so with Hartmann's than Plasmalite. There wasn't really much difference, to be honest.
Are there questions from the floor or from the co-moderators?
Yes, one comment. It's very, very great work, and I'm very happy to improve the use of a survey in each country that to work better than in this period. It's a very, very good job. Thank you very much.
Thank you very much. Thank you, and I hope you enjoy the rest of your day.
And I would like to thank all speakers for their excellent presentations, and I invite everyone for the coffee break. Thank you so much.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your invitation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new Rotaflow 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features that concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarms algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption matrix. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MEC procedures with an even more efficient centrifugal pump. The HL40 is the centerpiece of Getinge's surgical perfusion portfolio. Alongside the HCU40 heater cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator family. The first commercial units of our newer HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 system. I now leave the place to the video presentation, and I thank you for your attention.
We hope you enjoyed learning about our HL40 heart-lung machine. Getinge also offers modular tubing packs, providing a flexible approach with different table, machine, and accessory modules. This allows a perfusionist to choose a safe and reliable setup that's always available off the shelf. Modular tubing packs are available in Germany, Switzerland, and Austria, with other European market launches to follow this year and through 2022. I'd now like to present our next exciting product, the Rotaflow 2 system. This is a successor to our legendary Rotaflow centrifugal pump console. We have redesigned some major features to make ECMO easier and safer. This includes a new touchscreen with user guidance, a new holder design for improved intra-hospital transport, new battery management, and a new flow bubble sensor. We completed a successful limited market release in 5 German hospitals over the summer. All 5 centers were overall satisfied with the Rotaflow 2 system, with the new features very well received. Rotaflow 2 is now available in Europe, with more markets to follow soon. Now please enjoy a short video presentation on Getinge's newest ECMO product.
ECoPEaT is a new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters even in long and complex cardiopulmonary bypass procedures. The system is based on reliable and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
At Terumo Cardiovascular, we deliver trusted technology and clinical solutions focused on patient safety and high-quality care. We are continually investing in the future to help save one more life today and every day. Terumo has numerous best-in-class and unique technologies which are always evolving to meet patient needs. As technologies transform into new products, new goals appear. Continuous product improvement to create groundbreaking medical devices drives Terumo forward. Terumo Cardiovascular has led the way in oxygenator innovation and quality for more than 30 years and was the first and still is the only company to manufacture its own hollow fiber. Our unique approach to a wide range of oxygenators helps perfusionists to meet each patient's oxygenation and blood management needs more precisely. Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 milliliters, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 milliliters, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions. Smaller, slighter patients can have surgery with an oxygenator that best fits their unique metabolic needs. The increased blood flow rate available with the 3,000 milliliter hard shell reservoir expands the use of a smaller oxygenator to more patients. Listen now to what perfusionists are saying about the Capiox FX Advanced Oxygenator.
So the FX line of oxygenators has the most efficient gas exchange of any oxygenator that I've used in my practice. It also has a low pressure job. And then the safety of the integrated arterial line filter is what we really appreciate. Terumo's really taken the customer feedback and made small changes to design that have helped to improve the functionality.
The Capiox FX05 oxygenator is the world's first pediatric oxygenator with an integrated arterial filter. It offers low prime volume and high performance for the smallest patients. Terumo's lowest prime oxygenator has been priming volume of 43 milliliters and a maximum blood flow of 1.5 liters per minute. The Capiox FX05 oxygenator is ideal for neonatal babies and infants. Here are the experiences of perfusionists working with FX05 in their daily practice.
Capiox FX05's low priming volume and overall design address a variety of issues and concerns. Been our oxygenator of choice for the last 11 years.
Choose the oxygenator that expands your options and advances patient outcomes. Choose the Capiox FX Advanced Oxygenator. At Terumo, our technology is rooted in our unchanging mission to contribute to society through healthcare by responding, optimizing, and innovating. Everything we do at Terumo connects to medical settings and patients globally. We care about the right solution for every patient. It's all about you. Contact your Terumo sales representative for a demonstration or visit terumo-europe.com for more information.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your invitation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new Rotaflow 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features that concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarms algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption metrics. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MEC procedures with an even more efficient centrifugal pump. The HL40 is the centerpiece of Gettinger's surgical perfusion portfolio. Alongside the HCU40 heater cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator family. The first commercial units of our new HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 system. I now leave the place to the video presentation, and I thank you for your attention.
We hope you enjoyed learning about our HL40 heart-lung machine. Getinge also offers modular tubing packs, providing a flexible approach with different table, machine, and accessory modules. This allows a perfusionist to choose a safe and reliable setup that's always available off the shelf. Modular tubing packs are available in Germany, Switzerland, and Austria, with other European market launches to follow this year and through 2022. I'd now like to present our next exciting product, the Rotaflow 2 system. This is a successor to our legendary Rotaflow centrifugal pump console. We have redesigned some major features to make ECMO easier and safer. This includes a new touchscreen with user guidance, a new holder design for improved intra-hospital transport, new battery management, and a new flow bubble sensor. We completed a successful limited market release in 5 German hospitals over the summer. All 5 centers were overall satisfied with the Rotaflow 2 system, with the new features very well received. Rotaflow 2 is now available in Europe, with more markets to follow soon. Now please enjoy a short video presentation on Getinge's newest ECMO product.
ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to Connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
Good morning, everybody. Welcome back. It's time for our second scientific session. We'll have one speaker who won't be able to join us live, so that will be virtual. Hopefully it will work. We're here, 3 moderators, Dr. Peperstraat and Dr. Pappalardo and myself. The first speaker, I'm very, very, very honored to present Dr. Schmidt. He has a huge experience. As you know, he's from Paris, and they accommodated a huge amount of ECMO patients during the last pandemic. We all wondered how they organized it. So after this talk, I think no more secrets, because he'll tell us all about the logistics in Paris. After his talk, we'll immediately will go over to the questions, because Matthew has to go back. He just arrived this morning and he's going back immediately. So any questions, it's the time to ask him. Matthew?
Good morning, everyone. Thank you very much, Lynn, for this kind of introduction. I would like first to thank the scientific committee and the organization for this kind of invitation to talk with you about coordination of ECMO supplies and logistics in pandemics. So here are my potential disclosures. So early on in the pandemic, after the first cases in China, you may find some paper which describe how to plan the provision of ECMO care during a pandemic. So they say that it's a complex therapy at ECMO. It's very challenging to provide complex therapy such as ECMO in the pandemic. And you need to have an ECMO action plan, which is based on careful planning, judicious resource allocation, and training of personnel. This is very theoretical, but they say that to broadly, the organization of your ECMO should ensure appropriate organization of personnel, equipment, facility, and system. So these papers were useful, but probably this paper arrived a little bit too late for us. And clearly in Paris, we were not prepared at all to face to this large, massive surge of ECMO requests. And just to put it in a context, in March 2020, the literature potential candidate for ECMO was totally unknown. We even didn't know how many consoles and how many circuits were available in Paris and greater area. So just to put in context, Paris and greater areas, it's about 12 million inhabitants. And at that time, clearly the French system was totally overwhelmed with the urgent need of an increase of the ICU beds. ECMO was not the top priority for the French health direction and the regional agency. And even for hospital decision maker, what they wanted more ICU beds, and they didn't pay too much attention to ECMO. And the last part, which is also an important part, is that at that time we didn't know if the industry will be able to provide us more circuits and more consoles, because there was a shortage of resources due to the stop of some factory in Asia and Germany. And despite not being prepared at all, during the first week of March, after the first patient in my department in February, we decided to organize this ECMO activity by following 4 steps that I will detail with you. The first one was to know what was available in Paris and greater area. So with the help of the biomedical industry, we were able in almost a week to list how many ECMO supplies were available in Greater Paris. For some centers received console circuits during the H1N1 pandemic, but didn't even use it at least once. And it was very important in the discussion with all the ICUs in Paris and greater area to be sure that they do not hoard supplies. And this first contact with all the ICUs during the first week of March had quite a benefit effect because we were able to have a positive and constructive discussion with other ICUs. And on March 10, we were able to know that our starting point will be 165 ECMO console and 389 circuits available among across 30 hospitals in Greater Paris. 19 patients were already on ECMO when we start this program. And you see that rapidly the available console markedly decreased rapidly. So at the end of March, after only 1 month, we were at only 24. We, as you can see, this is a daily implantation of venous ECMO during the pandemic, during the first wave of the pandemic. And you see that the peak was reached on March 31 with 14 ECMO implied start during that day. It was also important to identify which ICU were able to care for this COVID patient on ECMO. So we identified 3 centers with a large ECMO volume, 3 centers with who have done 10 to 30 VV ECMO patients in the previous year, and the majority of centers had done only less than 10 cases in the previous year. And during that time, in this 17 ICU, the ICU beds capacity moved from 500 beds to more than 1,200. And it was also important to have more mobile ECMO team to rescue this patient. So normally, in normal time, there is only one very active mobile ECMO team, and with the help of private and public cardiac surgery center, which at that time most of the surgeons didn't operate because everything was closed and stopped. So we were able to increase the number of available mobile teams up to 6 mobile ECMO team available. So you see that even if the work was not homogeneously distributed between these 6 mobile ECMO team, but you see that almost everyone did a part of the job, even if the team A did much more. The second step was to set up a working process, because we know that at that time supplies were scarce, and we needed to define rapidly rules and to control the availability of the devices. And we needed also to reserve a couple of console and circuits for non-COVID-19 indication for cardiogenic shock and post-cardiotomy. So we decided to allocate almost 20 circuits and ECMO console for this indication. And it was quite obvious that at that time we needed to homogenize ECMO criteria and management. So for that we create, again during this first week of March, which was an intense week, we create a Paris ECMO COVID task force, which gather all the head of the COVID ECMO ICUs and the head of all the mobile ECMO teams. And with this group, we rapidly defined the working process, which implied to share equipment and human resources. We wrote guidelines for ECMO indication organization, and we initiate a system to have a rapid feedback on the efficacy, but also the strategy in place. So we define together what is the acceptable indication for ECMO in that context. So we mainly use the EOLIA criteria, except that we said that positioning should be almost mandatory in this context with quite limited resources. And we say that we should have a strict application of the EOLIA criteria. We focus a lot on the contraindication for ECMO at that time because this was not very well defined in the EOLIA trial. And we said that age over 65 should not be a candidate in that context. Severe comorbidities, severe immunocompromised status, cardiac arrest, obviously we stop the activity of ECPR during that time. And we defined that mechanical ventilation duration over 10 days was not a good candidate, meaning that the patients are less likely to benefit from the technique. And in the following weeks, we even had another criteria, which was a BMI over 40, because this patient, we saw that this patient had a very long ECMO run with quite uncertainty of the benefit. And what was important at that time is that together we decided to centralize the indication for ECMO, meaning that everyone who wants to start or to put an ECMO into a patient in Paris and greater area, in all ICU in Paris and greater area, should call a hub, a phone, there is a central line to centralize the indication for ECMO, and this was clearly based on the need to use ECMO on expertise and science-based medicine and to avoid compassionate use and futility. It was also useful to centralize ECMO indication to avoid tension between ICU and mobile ECMO team. And it was also very useful to maintain an accurate and up-to-date inventory of the equipment available. So by this way, we were able to know day by day how many console, how many ECMO devices were still available. And to be sure that it was validated by all ICU in Paris and greater area. So this criteria, this organization was validated to be sure that everyone will follow the same rules during 1, 2, 3 months. We didn't know at that time how long it's going to be. And for legacy, we had an official endorsement of this ECMO indication and this ECMO organization by the regional health agency. It was also endorsed by the National Federation of Intensive Care in France. So in practice, we did this regulation of cannulation and bed management. So when you call the ECMO COVID-19, which was based in my department for an ECMO indication, when the indication was validated by our team, when ECMO was approved, our job was to find which mobile team was available at that time to set up the ECMO and which ICU will be available to manage and to care for this patient. So in total, during 2.5 months, we received more than 575 calls for ECMO for patients with COVID-19. We didn't say yes every time. We approved ECMO for 302 patients. ECMO mobile team did more than 212 cannulation, and we did lots of transfer between ICUs. So this is just to show you that we start ECMO, we implant ECMO beyond Paris downtown. We went quite far away, 100 kilometers around Paris downtown. And the third step was to have communication, to have information, to have feedback. And for that, we organize every day. We had a daily report, email to all relevant stakeholders and agency to know how many devices were still available. We had a validation at some point when the resources were very scarce. Even the change of the membrane, change of the circuit should be approved by our team to avoid wasting circuits. And we use a WhatsApp group to facilitate communication between the ECMO mobile team and the ICU ECMO teams. And the last step, which is the step 4, was dissemination of information. So we organized weekly web meeting to summarize ECMO activity, to update all center on special issue, to review also the cases where VA was needed or VAV was needed, to discuss thrombotic and risk and strategy for this patient, which was a challenge at the beginning. And we tried to get early outcome to know if we were on the good tracks. We published this experience, which was a great reward for all the participants to this experience. And the mortality is quite high, with 54% mortality. We were able to extract some risk factor, important risk factor, mainly that the caseload in the previously was very important. And you see that the mortality is almost twice in center with less experience. We show also that transferring patient on ECMO to use a mobile ECMO transfer was not an issue at all, with the same prognosis for patient cannulate on-site or outside. We also review our call to see if we had the right indication, and we published that more recently to show what was the prognosis for those patients when we say ECMO, why not, but not now, meaning that you can call me back tomorrow, but you have still to improve the ventilation of your patient or do one additional prone position session. And you say that the mortality of this patient at 90 days is almost the same compared to ECMO patient. However, when you look at the prognosis of those patients when we say ECMO non-ever, meaning that this patient will never get an ECMO because he's too sick or is ventilated for a too long time, you see that the mortality at 90 days was quite low, with less than 15% survival. So today it's more an experience sharing rather than a complete recipe. Probably this organization, this experience should probably have an adaptation for each national ECMO regulation organization. I think some key points are, during a pandemic, we should do early ECMO management in experience center first. Centralization and regulation of ECMO indication help to prevent a shortage of resources. Feedback, corrective action, effective coordination, communication are probably the key points. You should be prepared and trained. It's easier to say than to do. And hopefully, from my side, I hope it was the first and the last time we face such a nightmare. Thank you very much.
Thank you very much, Mathieu, for sharing your impressive experience. Yes, and I hope also it was the first and the last time, and that we can talk about past time already. Are there any questions first from the audience before I turn to my co-moderators? This is a European meeting. People are a little bit shy to ask questions, but you can ask them in French. He speaks French also. No. Then I'll turn to my co-moderators.
Yeah. So thank you very much, Mathieu, for your excellent presentation. I have a question which is more, philosophical. So we have learned a lot about logistics from this experience, but what did you learn in terms of general concepts of ARDS and ECMO? So what is the lesson learned in terms of this kind of management and decision process?
I think we are still learning, because actually we are facing the fourth waves with patient profile quite different from the beginning. I think what I learned actually is that we always consider invasive mechanical ventilation duration in our criteria for ECMO, but I think we always forgot the management before the invasive mechanical ventilation. And what we saw in the third and fourth wave is that you have patients who spend 2 weeks on high flow nasal oxygen or NIVs and being intubated. And when you intubate them, the compliance is already totally very small, short compliance. And I think we should probably pay more attention to this pre-intubation part, which probably are one of the key factors that may explain why we have an evolving mortality in the third and the fourth waves.
Mm-hmm. And do you see a role in this scenario for ECMO without intubation?
So we have done that a couple of times. We have some success, but also failure. With COVID-19, it might be maybe easier compared to another bacterial pneumonia because, as you may have seen, this patient tolerate pretty well the hypoxemia, which has been called silent hypoxia. So we have done that a couple of times. It may work for some patient. You need to have a strong agreement of the patient first. And also you need to be aware that at some point you need to stop and to intubate the patient. And I think it's not valuable to let the patient breathing at 40 or 50 per minute, even if he's feeling not so bad, but the damage for the lung are huge.
Thank you.
We have a question from the audience there.
Yes, thank you for a great presentation. I have a question. Can you share what was average percentage of lung injury on CT when you started ECMO, after you started ECMO?
I don't have the right number, but what I remember is that for most of them it was more than 75% of lung damage on the CT scan.
And maximum?
Maximum is 100% for most of them, probably.
Thank you.
Mathieu, I also have a question. As a perfusionist, I have to ask a more technical question. You said that you were discussing the change out of the oxygenators according to certain markers. Which were those markers, and were they different than before, and did they change over the pandemic?
No, it didn't change too much, but what we didn't want is to have a waste of circuits for very light hemolysis, for example. Sometimes frequently you can just decrease a little bit the flow and the hemolysis solve by herself. So it was more in that perspective to avoid wasting circuits, especially for centers who were less experienced. But we applied exactly the same when you have a strong hypofibrinogenemia, when you have a strong hemolysis, when you have obviously thrombosis of the membrane, you should change it. But it was mainly to avoid wasting circuits. Because as you have seen on the graph, we end up with only 25 circuits and ECMO console on Paris, on whole Paris, with the inability of industry to provide us more devices.
Okay. Any more questions? Thank you very much, Mathieu.
Thank you very much.
Have a safe flight back. Oh, okay.
Okay, and I'm very happy to introduce Christophe van den Brille. He's taking us to the walking the line anticoagulation and thrombosis in mechanical circulatory support.
Thank you very much for the introduction. Thank you for the invitation as well, and I'll try to guide you in 20 minutes to our anticoagulation management we use nowadays in our hospital. It will be a short one, but I'm happy to take any questions afterwards. So, as we all know, we should avoid bleeds and thrombotic complications in those difficult patients we have to manage with mechanical circulatory support. We fear the intracranial bleed, but we also fear the daily bleeding problems. And we know that bleeding is very common in mechanical circulatory support patients, and some centers report up to 80% of major bleeds. This is a study we did ourselves a while ago, and we see indeed that the major bleeding incidence in mechanical circulatory support, whether it's Impella or VA ECMO patients, is quite high, and we should do something about it to avoid these catastrophic complications and to reduce the morbidity and mortality in this patient group. So something we would like to avoid is, of course, clotting of our oxygenator, clotting of pump problems, clotting inside the patient, clotting inside the heart, as you can see on this patient on VA ECMO, where the LVOT is completely obstructed due to the high afterload. And coagulation management in those patients is still an open research field, and I strongly believe that it improves your outcome of percutaneous mechanical circulatory support. So key questions are: which anticoagulant should we use? Which anticoagulation level should we aim for? And if we go for a level, how should we monitor this anticoagulation in those critically ill patients? Those are three basic but still resolved questions. This is another nice study, and as I'm aware, it's the only one that looked at thrombotic complications in patients on mechanical circulatory support. So they did an autopsy in all of their patients who died after a circuit run, and they found that 80% of those patients had clinically unrecognized thrombosis in all kinds of organs, microthrombotic complications, renal infarctions, and so on. So we try to manage those bleeds, but at the other hand, we also have many unrecognized thrombotic complications, which we also should tackle in those ICU patients. So it's not easy. So I'll give you a brief overview of coagulation on MCS and a brief refresh of the anticoagulation system in those patients, the most commonly used anticoagulation tests, and how we should monitor, as I believe, unfractionated heparin in this patient group. So, anticoagulation in mechanical circulatory support is completely different from non-MCS patients. And why do they bleed? That's because of the artificial surface, the high shear stress, and so on. So we get contact and activation, mainly due to consumption of factor 11 and 12. The high shear induces the acquired von Willebrand syndrome and the loss of high multimer molecules of von Willebrand, which will prone you to bleeding complications. And also the high shear and the plastic surfaces will cause platelet deposition, platelet degranulation, and at the end platelet consumption, which will be the subject of the next talk. So this is a nice figure actually of fluorescent labeled platelets on the surface of an ECMO cannula over 6 hours. And as you can see, those fluorescent platelets, they float with high shear stress over the plastic surface of the membrane, and they become sticky to the fibrin deposition formed on the plastic surface. So factor 11 and 12, albumin, etc. will form a nice biofilm, and the platelets will get attached to them, and that's why we mainly see after a couple of days that the platelet counts go down. They just get sticky to the surface, they get activated, they degranulate, and they won't work anymore actually. So this is this is a patient on Impella actually. After 1 hour of run, you see that there is a complete loss of the high molecular weight von Willebrand multimers, so this patient is prone to bleed. And when the patient goes off pump, and this is only 1 hour after switching off the Impella, the molecules are back. So this is something that goes off and on very quickly, and we need to be aware of this. Is this not something that develops over days, but over hours? So this is a cartoon we recently published, and you can have a look at the publication if you want to, but these are all kind of coagulation tests that are available nowadays in a modern coagulation lab, and how you should learn or use or interpret them in patients on mechanical circulatory support. And they can go from quick tests to very advanced tests that take days and days, etc. But I think the key message of this cartoon should be that it can be rather complicated, and that we can't use and wait for every test in every patient, because it will
takes some resources, it's very expensive, and we simply don't have the time to wait for them. So we'll have to find a balance and a nice way in this way of monitoring those patients, how we should tackle this in daily ICU. If we look at the ideal anticoagulants in ICU-managed MCS patients, it should be easy to reverse, or it should have a rapid offset, short half-life, but with a rapid onset of work, low renal excretion, because all of them have acute kidney injury, simple PK/PD, because those patients have liver injury, liver failure, acute kidney injury, and this changes every day, but also easy to monitor, and it should also come with a low cost. So unfortunately, nowadays we don't have this ideal anticoagulants yet, but we still mostly use in most centers unfractionated heparin because it maybe approaches all of those things the best so far, especially the low cost. But this is also something we published last year, where we discuss all the other things that you can use on mechanical circulatory support in the ICU to support your patients. It goes from direct thrombin inhibitors, bivalirudin, agatroband, even centers who use citrate, which I wouldn't advise. You can use special cannulas, oxygenated surfaces. There's lots of research going on about biomimetic surfaces with nitric oxide donation, etc. Many centers do not run with anticoagulation, especially not in VV ECMO. And then there's lots of discussion whether you should add aspirin or not, and so on. And we could talk hours and hours about this, but due to time, I can't go deeper on it. But you also see which test is advised in which direct and which anticoagulants, etc. So you can have a look if you want to. So I'll mainly continue my talk by using unfractionated heparin because I think that's still the main anticoagulants used in our daily ICU. So again, this is another scheme where we look at those tests that are available, and I'll go deeper in on the APTT and the factor 10 levels because those are easy available, are probably the best to use, are short notice to have your results, etc. But do know that there are many other tests that can be used in very specific situations or even in research situations. So how should we monitor parenteral anticoagulation? So we try to reflect the level of anticoagulation as accurate as possible in order to prevent thrombotic complications, that's what we want, but also with a minimal risk on bleeding events. So that's a very, very difficult balance, and we try to find the best approach and the best tests to reach this target. So the INR is probably not useful in monitoring your parenteral anticoagulation. It is useful when you have patients with liver problems to see whether they bleed due to the liver or due to the heparin you're giving. So you should monitor it daily, but not to guide your fractionated heparin. APTT and anti-10A are, as I believe, the preferred tests, especially when you work in a hospital where it's 24/7 available, optimized, and when you have the results in 40 minutes. When this is not the case, it might challenge your anticoagulation management. I do advocate that you should not use ACT because ACT is a good test to use it in a cath lab when you give a bolus and when it's white or black and you want to see whether your bolus is working. But when you really want to fine-tune your level of anticoagulation, especially with heparin, I would not advise using ACT, although I do know that many centers still use it. Monitoring can be very challenging, and I think the main message of my talk today should be that there is not a single test that will give you the results in your management. So there's one test fits it all. So we mainly use at my hospital especially two tests, the APTT and the anti-10A, and I'll guide you through this. So the APTT is actually a very simple test. You use a bit of plastic, kaolin or whatsoever, silica, and that will activate factor 12, go down to 11, 9, via 8 it goes to 10, factor 2, and at the end you get a fibrinogen fibrin clot, and the time it takes from the activation until the clot formation in seconds, that's your APTT. It's very easy. The other test is the anti-10A test, and that's a more expensive test. It's not as easy to make it on an automatic machine, but it's feasible. And it works on a completely different way, actually. What the anti-10A test does is it looks at the heparin antithrombin complex. And when there's lots of heparin antithrombin inside the blood, it will bind the dye you add to the blood, and this dye can be excitated by some light, and this excitation will turn your plasma into yellow. That means when there's lots of heparin antithrombin inside the blood or the plasma of your patient, there will be lots of dye bound. So at the end, your plasma will turn less yellow. And the opposite is true if there's less heparin. So the more yellow your plasma turns out at the end, the less heparin antithrombin complex you will find inside the blood of your patient. So this is a direct way of measuring the concentration of heparin antithrombin complex in the blood of your patient. This means also that there's an important lack if your patient has already yellow plasma, so in high bilirubin levels and liver failure, this test won't work, so that's a limitation. So I'll show you quickly 4 results why you should always use APTT and anti-10A simultaneously, and why not one test will give you the result, and I'll show you why. So this is a patient where we measured the APTT 1 hour, 2 hours later, 2 hours later. And you can see it flips. It goes from 60 to more than 180, and then it flips back. And this is quite strange. And if you would only measure the APTT, you would say my heparin level is way too low. I should come down with my heparin. But this is something very common, actually. And if you go down to the cascade, you can see why this might be that it flips down, and if you add the anti-10A, it's completely in range. So I wouldn't come down with the heparin, but there should something be wrong with your APTT test. And if you would only follow your APTT, you would come down with the heparin and you risk thrombotic complications. So those are the ranges we keep our patients in, APTT and anti-10A, but we guide the heparin based on anti-10A. So for a VV, 0.2 to 0.3, 0.3 to 0.5 for a VA, and if there's an active clot, we go to 0.5 to 0.7. But in parallel, we measure the APTT. So why is this APTT flipping, going off and on? And that depends on your lab, actually. We know that there are certain cutoffs in the lab of fibrinogen. If you go up or down that level, that the APTT will flip, and that depends highly on the machine, and it's a lab value, a lab default actually. For my hospital is 0.6. If the fibrinogen goes below 0.6, your APTT will prolong, and if it goes up to 0.6, it will get normalized again. So that was the reason in this patient why the APTT was flipping. The second example was this one. So we have an anti-10A that is very low. We can't measure it. The antithrombin is very low, so you can see that the heparin antithrombin won't work. So that's the reason why the anti-10A is low. But also the APTT was strongly prolonged, and that's why we also had a fibrinogen because we also had a fibrinogen depletion. So here we have a combined APTT that we can't use and an anti-10A that we can't use. For example, in a severe septic patient where the fibrinogen and antithrombin production is deficient. So that's very difficult, and maybe we can use rotamortec in those patients. We don't know, it's not validated. But those are the cases where you don't have anything to monitor those patients. But if you think about it, and if you measure the test, it can give you a clue what the problem might be. This is not heparin, this is patient-related. In this patient, we had an APTT that was very prolonged, so it's very long, and the anti-10A was in range, and this was due to factor 11 and factor 12 depletion. In the long run, the 11 and 12 stick to the plastic surface of the patient or of the ECMO, and the APTT is strongly prolonged. So when you did not have the anti-10A, you would come down with your heparin. But we know that patients with 11 and 12 deficiency have a long APTT but do not bleed. So in this case, you would look at an artificial prolonged APTT, and you would come down and risk thrombotic complications. And due to the matter of time, I'll go quickly through this. So this was a liver patient. So he had a long APTT, liver problems, so 9 and 10 is no longer produced, anti-10A is in range, so your heparin is probably okay. What this means for the overall bleeding rate in this patient, we do not know actually. And that's why you should always measure anti-10A and APTT simultaneously and then make a decision what you will do with your levels in both ways. So we know that if the APTT and the anti-10A is divergent, so if you measure them parallel and they are divergent, that this will increase your mortality, and that's logical. Either you increase mortality because you risk thrombotic complications, because you come down with heparin when you shouldn't, or you increase the bleeding risk because your patient is having bleeding complications like 9 or 10 or whatsoever is no longer working due to liver failure. So my advice is always measure both simultaneously, and this will give you the clue. So this is a study we did on our own. When we guide through anti-10A, we have less bleeding complications, less thrombotic complications, less measurements, so it's cheaper, and we have better outcome as compared to APTT. So I believe that a daily coagulation on a patient on mechanical circulatory support should look like this. Measure your APTT and heparin simultaneously, INR once a day, D-dimers and plasma-free hemoglobin to measure your circuit performance, etc. So in conclusion, parenteral anticoagulation on mechanical circulatory support can be very challenging. Pick the right test for the right product and the right patient. And often it's no one test fits it all, but guide your heparin based on anti-10A to avoid thrombotic complications and monitor your APTT in parallel to avoid bleeding complications. Thank you very much for your attention.
Thank you, Christoph. So as the next presentation is going to deal with coagulation, I think it's better if we discuss at the end of the two. So I invite Matthias Lubnov to the podium to give his talk about consumption coagulopathy.
Yes, thank you very much for the kind introduction and the invitation to talk about consumption coagulopathy during ECMO therapy. These are my conflicts of interest. And if we do extracorporeal membrane oxygenation, we suction blood through a cannula with high shear stress. Then the blood passes a pump which rotates at high RPMs, and you don't have you can imagine that thrombocytes will be activated and degranulate during this process, and then the blood is expelled into the oxygenator, where the blood flow comes down, where you have a huge foreign surface, and then after the blood passes the oxygenator, it's given back with shear stress into the body. And even so, you have biocompatible coatings with our machines. You can imagine that we will have at first shear stress with mechanical blood trauma, thrombocyte dysfunction, and von Willebrand factor dysfunction, as Christoph already told you. And due to the foreign surface, we had activation of thrombocytes, leukocytes, and activation of the coagulation. If you use an extracorporeal system, you will get this as a result. So even so, we do not use these historic ECMO machines anymore from the time when I was born. But we use the modern miniaturized ECMO systems with centrifugal pumps and PMP membranes and biocompatible coating. You still have a foreign surface, and you will have contact activation of the coagulation cascade. You will have activation of the platelets, a platelet degranulation, and you will have as well complement activation. And there's an interplay between inflammation and coagulation due to this cascade. So you will have an inflammatory response and coagulation response to your extracorporeal systems. And there are numerous extra vivo studies which show the depletion of the specific factors and the inflammatory response. But most of this system miss the main point why we are doing ECMO. That's the patient. And the patient is the biggest black box in our system. We do ECMO because the patient has severe pneumonia, sepsis, or cardiogenic shock and thirst, and the patient might have coagulation disorder, and he might have multi-organ failure, and he might develop organ insufficiencies during the course of his disease. So we don't know at what time point the patient is able to produce coagulation factors. And the interplay between the organ insufficiencies and the consumption of coagulation factors in the ECMO machine will cause the consumption coagulopathy. And for us as clinicians, the consumption coagulopathy is important when the patient starts bleeding. But then often it's too late. You should act a little bit before the patient starts bleeding. I told you launching up an ECMO machine will cause inflammatory response. But if you look at studies which check the inflammatory parameters of patients who were put on ECMO, you always see that you have a steep decrease in the inflammatory response, because the underlying disease is much more important for the inflammatory processes in the body than the inflammation caused by the ECMO machine. What happens to the coagulation then? And therefore we did a small prospective randomized observational study where we tested 3 different ECMO machines in ECMO patients, where we excluded patients with activated coagulation who were on, we excluded dialysis, CRT, trauma patients, and an operation 48 hours before the ECMO start. Our standard anticoagulation was unfractionated heparin with a goal PTT of 50 seconds. And what you can see, in general, the 3 systems do not differ very much from each other. But what you can see over time, we lose platelets. They drop by 50% during the first 5 days. Always the first measurement is before start of ECMO, and then the first 5 days during ECMO therapy. You see that the TUT complex and the FAB fragment are increasing, so we have some coagulation activation, and we have a slight increase in D-dimerase, also respective of coagulation activation. When you look at factor 13, most of our patients had, before they started ECMO, a factor 13 level of around 80, and this only slightly drops. And if you look to fibrinogen, you see as well a slight decrease in fibrinogen, even so it stays normal. And one glance to the inflammatory parameters, even in these patients, the inflammatory reaction comes down due to the treatment of the underlying disease. So we see in vivo experiments, the inflammation comes down due to the underlying illness, to the treatment, and it's not accelerated by the ECMO machine, but we see a slight activation of the coagulation and consumption of coagulation factors. This was also seen by others. That's the Freiburg group, the anesthesiologists, and they see a decrease in the factors even to a greater extent than in our study. But this was mainly related to the circuits they used at that time. They had 2 oxygenators, and the higher the foreign surface, the more consumption of coagulation factors you will have. So then another point or another time point to look at the coagulation is the end of ECMO therapy. Usually at the end of ECMO therapy, the underlying disease is treated or has much improved. So the effect of the ECMO on the coagulation should be more visible. And so we did a retrospective study on survivors which have been at least 5 days on ECMO. And we looked at VV and VA ECMO patients. And we found in this collective, with this definition of coagulopathy, consumption coagulopathy in 13% of the VV ECMO patients and in 10% of the VA ECMO patients. And I guide you through the slides. What you see is the first measurement at the end of ECMO therapy, and then the 2 days after we have finished the ECMO therapy. The white bars is the group with the patients with consumption coagulopathy, and the gray bars are the patients without. And what you can see is that the consumption coagulopathy resolves when you stop the ECMO treatment, but it takes some time. But you see as well in the group with the patient without consumption coagulopathy that the fibrinogen is increasing. So there is some consumption of fibrinogen by the oxygenator. And the same you can see with the D-dimers. The D-dimers are elevated and they decrease during the 2 days after finishing the ECMO treatment. And inversely, the platelets come up during the first days after ECMO treatment. So we have consumption of platelets and we have consumption of fibrinogen. And is there a difference between VV and VA ECMO patients? And as well, you have patients with coagulopathy with white bars and without coagulopathy with gray bars. And you see the same pattern in VA ECMO patients. Fibrinogen comes up, D-dimers come down, and thrombocytes come up. But there's one main difference. The thrombocyte count is lower in the VA ECMO patient than in the VV ECMO patients. So because of the higher pressures and the higher RPMs, we probably have more consumption of platelets in VA ECMO. So it's good news when my patient has a consumption coagulopathy and I can terminate the ECMO therapy that the coagulation disorder resolves. But what to do with patients who get an ECMO-related coagulation disorder while being in ECMO and still need ECMO therapy? And so we looked up our database and identified roughly 10 to 15% having a coagulopathy on ECMO. And we found 2 distinct groups of patients who started bleeding on ECMO. We had one group which has elevated D-dimers and low platelets, and another group which had additionally low fibrinogen. This might be a continuum with a more progressive or a progression of the disease. But these 2 groups we saw. So, and the question is, when you now exchange the oxygenator, does the coagulation disorder resolve? And there you just have to keep one thing in mind. How does it look inside an oxygenator? And here you see electron microscopical pictures from the fibers, and you see that the thrombus formation starts at the seam between the fibers and at the contact points between the different fiber layers. And once it progresses, you have this fibrin net, and you can think of it like a fishing net, which fishes thrombocytes, erythrocytes, and maybe more fibrinogen. So if there is thrombus, this might cause more consumption of fibrinogen and thrombocytes and so on. And I think, or we think, that the consumption coagulopathy is mainly caused by the oxygenator. So when you now exchange the oxygenator, what happens to your lab values? And you see on the right side the patients with D-dimers and platelets with local fibrinolysis. Here's the first 5 days before the oxygenator exchange and then the 3 days thereafter. And you see that D-dimers come up, and after the oxygenator, they come down. The fibrinogen just drops slightly, but then starts to increase again, and the platelets do the same, but stabilize. And the patient which have already a decreased fibrinogen, you see as well the D-dimers come up. After the exchange of the oxygenator, they come down. The fibrinogen drops to below 200 and then stabilizes, slightly rises, and the platelets do the same. So you can convert, or you can, and the patient stops bleeding. So you can stop the ECMO-related coagulation disorder by exchanging the oxygenator. And the problem is now we had patients who stopped the coagulation disorder, but then again they had a low fibrinogen, high D-dimers, and low platelets, and you can't stop the ECMO therapy. And the patient bleeds from surgical sites, from the lung, from the cannulas. So what to do, or what are your options? And your options are, based on your results, you can add tranexamic acid, you can give fibrinogen, you can give fresh frozen plasma, platelets, and you have to treat the underlying disease, because the patient probably is now the problem. When you have exchanged the oxygenator, the patient isn't capable of producing enough coagulation factors. So look for infections in the patients. And sometimes, in this case, a rota might be helpful, because you identify patients which might have only a hypofibrinogenemia, and you can substitute fibrinogen. So let me conclude. ECMO leads to an activation of anticoagulation and inflammatory systems, but the underlying disease and the individual patient characteristics are very important in the setting. Consumption coagulopathy consists of cellular components. You have thrombocytopenia and thrombocytopathy. I haven't mentioned it, but we measured as well multiplatelet function tests in our ECMO patients. And most of these patients have severely depressed platelet function, like being on double antiplatelet therapy and a GP2B3A antagonist. So the platelets don't work. Then you have plasmatic disorders like deficiency of coagulation factors, von Willebrand-Jürgen syndrome, and hyperphenomenalis. And for us as clinicians, we decide asymptomatic coagulopathies and symptomatic coagulopathies. And if the patient is bleeding, think of terminating the ECMO system, think of an oxygenator exchange if you cannot terminate ECMO, and substitute the missing factors. Always avoid all invasive procedures in your ECMO patients, not to end up in a mess. Thank you very much for your attention.
Okay, I think we can start asking questions. If Christoph can
join
come.
us.
Yeah. Professor De Zomer will start.
I would like to ask a question to Dr. van den Briele. Thank you very much for your presentation. It was very informative. But I was wondering, you said we have to focus on APTT. But if we use that, we have one disadvantage, the fact that we work on a plasma test, meaning that we actually exclude the cellular components. Now, if we look to the major impact on platelets, and we do know that the surface of the platelet, especially of activated platelets, is an amplificator of thrombin generation, shouldn't we focus more on the effect we can have on platelets? For example, in VA, we sometimes see when it's a post-cardiotomy that there should be fibrinolysis, which is known to actually have a negative effect on the 1GP receptor, which is then giving bleeding. So shouldn't we then be more interactive by monitoring this and, for example, giving faster tranexamic acid, for example, in order to control that?
Yeah, that's a very good but difficult question, and I agree that there's lots of interaction between those two. I always monitor, it's not the APTT I would focus on, it's the NT10A. I would use both tests to measure in parallel, but you're right, there's lots of interaction of those platelet functions, and we've done for a while, for research actually, platelet aggregation tests, and we looked what the effect might be of those platelets in those circuit managed patients, and we saw actually that the first days those platelets were still working a bit, but after a few days the aggregations were completely flat. So I'm not sure how we should interpret the effect of platelets on mechanical circulatory support patients after a few days. I think in the first upcoming days, when the circuit is novel, when the patient's still sick, it's very inflammatory, etc., there's a huge interaction. Should we give aspirin in the first days? We might be, I don't know. That's a very interesting trial we should do. But I think after a few days that those platelets are so degranulated and ineffective that the additional effect might be less. Of course, that's completely different in a CPB patient group where you go to theater, do your intervention, and they come to the ICU for only a couple of days. That's a completely different group
What I would like to ask you in addition to that, shouldn't we go to tests where we actually can measure thrombin generation? Because now we have them available for plasma. They are under validation for whole blood.
Yeah.
But that maybe could help us to prevent this issue with the platelets at the later follow-up of the ECMO. So if we would know from the beginning what was the potential of a given platelet to generate the thrombin, and eventually then interact with some drugs.
Yeah, it's true. The thrombin generation was on one of my slides. We discuss it in the paper, and our conclusion is actually that it's a very good and nice test, but it's not easy. It takes a while. You need a very good coagulation lab. You need it 24/7, and at least in my experience, the results can be very fluctuating. So, but I think at the end, it might be a good way to go. Yeah.
Thank you so much.
I had also a question for Christophe. I was just wondering if you, because we saw a slide where you have your anti-10A level you want to reach for VV, for VA, and then another group of patients.
Acute thrombus.
Yes, okay, acute thrombus. But I was just wondering, for example, if you have a patient in heart failure who gets acute heart failure, who gets an ECMO, does it change your heparin plan, or you just stick to the plan, or an acute endocarditis who cannot come off bypass in the OR, or you stick just to that plan of anti-10A levels?
Yeah. That's a very important question, and maybe I haven't stressed it enough. Never stick to a plan. The level is always dependent on the patient in front of you, and you should always make the balance who is in front of you. If he's bleeding a lot, oozing through all the cannulas, I wouldn't go to a level of 0.5 or even 0.7. If your patient is running well and the circuit is doing well, I would go for the target you aim to, but it should be re-discussed and thought about it every single day. And I think that should be an important part of your ward round, to discuss what is our level today. And I was trained at the Brompton Hospital in London, and there we looked every day. We had to clearly mention what is our anticoagulation level today, what is our platelet target, what is our fibrinogen level, just because it was in the file, but also it makes you think about it and makes you think about how is my patient doing due to coagulopathy.
So I have a question for the both of you. You mentioned the very intriguing scenario of prolonged APTT, which is not necessarily, it's not necessarily related to heparin overdose. So I ask you how to react. So we understand that it's not driven by heparin. So do you exchange circuit, give plasma, stop heparin, do nothing? How do you usually react?
Usually we first exchange the circuit. Usually if the patient is bleeding, we stop heparin. And when the coagulation factors are coming up again, we start heparin again, and we discuss the level every day depending on the bleeding of the patient. So I think we have a three-step approach. You always have to see the patient and the bleeding of the patient, and you have to see your lab results, and then you have to define your goals.
Yeah, I think it's also important, based on the figures I showed you, that you try to ask your lab as quickly as possible to measure those rare but often seen coagulation disorders. And that also stresses the need of a good coagulation lab when you're doing ECMO in your hospital. It's not just the ICU, it's not just the pump, it's not just the perfusionist, it's not just the surgeon, but it's the whole team you need, and I think that's the strength or the weakness of a good ECMO facility. So at least we can have them in 12 hours, the dosage of all those coagulation factors, and I think if they're okay, then you should go on what we discussed. Yeah.
Any more questions from the floor?
I have a question. First of all, they were both very nice presentations. I know this is a very difficult topic, but I think it clarifies already a lot. I have a question for Matthias. You defined consumptive coagulopathy as being D-dimers above 30 fibrinogen. Do you wait until you reach those parameters, and because you say that's the definition, and then you will see further deterioration, or do you anticipate and say it's going that way? It's just to know when do we have to intervene.
It's a question: how much money do you have for oxygenators? As usually we wait, but usually the D-dimers come up for several days, and then the platelets start dropping, and the patient starts oozing, and that's the point when we.
So you wait until the patient starts oozing. Wouldn't it be better to prevent and
maybe we have to prove it? Yeah. I can't remember any patient we have lost due to bleeding or a bleeding complication in this setting, but the earlier you start exchanging your oxygenator, the more expensive your ECMO therapy will be. So that was the compromise we found in our hospital.
Yeah. Christoph, you want to comment on that?
Well, I think we're building up our experience, Alain. We've made our own protocol, whether we try to see whether we can prevent it. You need huge numbers, and I think as many things in ECMO, we definitely need urgently those trials, because there's so many basic questions which we still don't know. Can you run a VA on the same anticoagulation level as a VV? We don't know. So very interesting questions, but I can't tell you.
We have another interesting question there, Cornel.
Excuse me. I have a question for Dr. Lubnov. So you said if D-dimers increase, you can expect a decrease in platelets and fibrinogen after a few days. But when the D-dimers are increasing, are you screening for deep venous thrombosis, for example, in the patient? Because we had a few patients with venous thrombosis on ECMO. And yeah, what is your opinion about that?
Yeah, that's true. You always have to exclude other reasons for a D-dimer increase. Yeah, we always check for thrombosis somewhere else. But if there is no other reason for it, we found in a small study that the D-dimer level correlates with the clot size in the oxygenator. So we think it's a good measure for it, but you have to exclude differentials for D-dimer increase.
So you're screening for it every time you see an increase in D-dimers?
Yeah, and as well a nice parameter after termination of ECMO therapy, if the D-dimers don't drop by 50%, you should look for a deep venous thrombosis.
Okay, thank you.
Thank you. We should close the questions now, but if you have any more questions, you will find them both during lunchtime. And now we will, thank you both. We will move on, and this is a challenge. I hope it works. Now we have Professor Bilohlavek, who is going to give a virtual talk. Professor Bilohlavek is the current EuroELSO president. Is he there? Because we don't have a screen here anymore. I don't know if somebody can solve it. It's black. I see him. Hello, Jan.
Hello. Can you hear me?
We really miss you here live because it's a different vibe live as compared to in front of the computer. But we are very happy you made it virtually. And before you start, I also want to say to our virtual audience, there is a possibility to ask questions. I have here iPad on my knees, and all the virtual questions, they come here. So if you have a questions, you just send them online. So now it's my pleasure to introduce you, Jan, to talk about an area where you have gained a huge experience and published or recently published or are about to publish some very exciting data.
Okay, Lynn, it's my great pleasure to be with you. I'm really sad I cannot be in person with you all there, but as you know, there were reasons I couldn't come. So my task today is to introduce ECPR as a routine care for cardiac arrest patients, and I will limit my talk to out-of-hospital cardiac arrest, because for in-hospital cardiac arrest there is no doubt that this actually works well. We started with this activity almost 15 years ago, and the picture you're seeing here is from 2006. There was a patient, young female, who was resuscitated for 2 hours, and the patient died, and it was a stimulus for us to start with an ECPR program in our center. This is my disclosures. As you all know, use of ECMO increases rapidly, and it's boosting. And due to H1N1, a failed balloon pump study, and probably this year with COVID, we'll see many, many thousands of patients being treated worldwide. And ECPR is pretty the same. It's a very attractive topic. It's the kind of topic that everybody wants, because you have a patient who is dying. So the ECPR means to continue in conventional CPR, just using a mechanical device. So you have a patient who is dying, you put on ECMO, and the patient possibly survives. So this is so attractive that many centers around the world actually want to start with an ECPR program, and being not too much experience in regular ECMO programs, retrievals, and so on. So what I want to say as the first is that ECPR is the most challenging part of ECMO business and should be kind of a cherry on the top of the very routinely well-functioning ECMO center. However, it's still quite easy except for cannulation, because emergency cannulation in a patient who is in cardiac arrest may be challenging sometimes, but it's routine VA ECMO, which is connected to venous and arterial line, and you can see hopefully a picture with a patient on the unit who is under ECPR after prolonged CPR. I'll try to share with you one of our videos, but all of them look the same. The patient is being brought to cath lab in our setting, to emergency room in other institutions, usually under mechanical CPR, as you can see, and this is pretty effective, and you've got some time to cannulate the patient under ongoing CPR. We have an intensivist here taking care for the airways, for the neurological monitoring, and just for the whole CPR, and a lot of people around in the cath lab just helping you to stabilize a patient and put a patient on extracorporeal circulation. As you can see here, the patient is now on the extracorporeal circuit, and we start with further diagnostics and possibly therapy. If I just skip to one of the conclusions, who is the optimal patient for ECPR? It's definitely a patient which is in a refractory cardiac arrest, which is defined as a ACLS for at least 15 to 16 minutes, based on some studies showing that if you don't let a patient a chance to get a spontaneous return of circulation, then you will probably lose the chance for him to survive with conventional measures. On the other side, if you wait too long, you will lose the chance to get to the center for ECPR within a reasonable time to preserve neurological function. So definitely the time is the major issue in ECPR. And then, of course, no comorbidities. Should be a witnessed cardiac arrest either by EMS or in a public place, preferentially. We should expect correctable cause of cardiac arrest and of let's say, ongoing ischemia, like acute coronary syndromes. We prefer shockable rhythms, but we don't exclude actually non-shockable rhythms, mainly the PEA, which may be associated with severe pulmonary embolism. In selected cases, ECPR may work very well. Patients with intermittent return of spontaneous circulation are those patients who may benefit best from ECPR. And of course, logistics, and as I said, time to reach either the patient for ECPR or the patient reaches the ECPR center. That's of utmost importance in this setting. This is our cath lab prepared for an ECPR case. Of course, we monitor tissue oxygenation by nurse. We have a ventilator, Lucas plate for carbon plate for being radiolucent for performing coronary angio. And our team usually consists of intensivists, 1 or 2 interventional cardiologists, ICU nurse, 2 cath lab nurses, perfusionist, and data manager to follow what's going on, because the situation is usually very dynamic. The most frequent and actually expected cause of cardiac arrest is acute occlusion within the coronary tree. This is a typical cause of refractory cardiac arrest. A patient came in with proximal LAD occlusion, and as you can see, it's pretty simple for us to fix, but we need those 15 to 20 minutes to do it. And if we have been doing this in past under ongoing CPR, this is really not possible, and there was disastrous consequences by doing that. So nowadays, when the patient comes in refractory cardiac arrest, we put a patient on ECMO, and then we simply treat these lesions. To be honest, a lot of those patients end up in multiple organ dysfunction syndrome. This is a typical kind of patient after prolonged CPR for 51 minutes. The young lady had undergone prolonged multi-organ failure and the support, as you can see on the left-hand side, and then over tracheostomy, she recovered well. So we have a lot of survivors who have been resuscitated for more than 45, more than 50 minutes, and it's really possible to treat those patients, but the system must work, and we will talk about the system a little bit. What the data shows. The data show that if we look at the non-randomized data, some case stories and case series, and also the meta-analysis being published before this study, there is a lot of evidence that this works in selected patient groups, and definitely the survival of patients in ECPR in the proper setting may be better than survival of patients who have been treated conservatively or conventionally. This is data from Demetris Yiannopoulos group from Minneapolis, and this is the registry showing or study comparing ECPR patients in blue versus orange patients, who are patients in a placebo arm of other amiodarone study, nicely showing that in different time periods, the ECPR is always better, mainly in those patients who are being resuscitated more than 30 and more than 40 to 50 minutes, where basically conventional CPR after 50 minutes of cardiac arrest is futile. So those patients have chance only with ECPR. And as you can nicely see, and this is also our experience, the chance for survival is still reasonable, somewhere around 25%, 20 to 25%, up to 70 minutes. So this is important to know, that there is somewhere between 60, 65 minutes usually. There is a timeline or time deadline where we are very reluctant to put a patient on ECPR. However, still, even after 65, 70 minutes, there is some survivors, and this is sometimes very difficult to choose the right patients. Last year, it's almost exactly a year ago, the first randomized trial has been published in Lancet by the same group. Only 30 patients being randomized to conventional versus ECPR approach. Those patients who had at least 3 shocks pre-hospitally, they were brought to hospital under ongoing CPR, and after 50 minutes of CPR on admission, they were randomized either to ECMO or to standard ACLS. And as you can see in red, this is the standard group patients. The outcome was futile. Basically, all of them died except for one patient who survived for first 3 months, but he was with a bad neurological outcome, and he died ultimately. In contrary to ECPR ECMO patients, where 6 of those 15 patients survived. And this study was stopped by the SMB for a benefit of ECMO group. So this is the first randomized data we have. So this might look very well and very successfully, but the group of patients is small, and it was a 2A phase of the study. During the same year, actually, other 2 interesting studies have been published. This is a large series from Canada, from Brian Gruneau, more than 27,000 patients in cardiac arrest, where by a matching, they compared intra-arrest transport versus on-scene resuscitations. And in this very large prospective group of patients, 4% in those who had undergone intra-arrest transport versus 8.5 patients who were resuscitated on scene survived. So you see, there's a problem. Patients who were transported for a possible ECPR died more and had a poorer, worse prognosis. And this is nicely shown here in the first plot. But what is important is to show this subgroup of patients. This is a subgroup of patients which did better by intra-arrest transport, and you can see it's those patients who have been resuscitated for more than 30 minutes. So patients who were in true cardiac arrest refractory to conventional CPR had been resuscitated for more than 30 minutes. Those patients survived much better when they undergone intra-arrest transport, and eventually they were put on ECPR. The other study, the Norway study, again published recently in 2021, has shown that the system may play a big role. It's, again, not so easy to implement ECPR. This study actually compared two periods of treatment approach, the pre-ECPR and the post-ECPR implementation. And as you can see here, patients before implementation, the CPC score was better than in patients after the CPR protocol implementation. So the survival was better with conventional measures versus ECPR period. So there is probably some problem in what we are doing, and we have to be very careful when implementing ECPR. And within this context and milieu, I hope soon our study will come out with, which has been presented already, and I can share the data with you. We have performed actually within past 7 years a prospective randomized controlled trial. We call it hyperinvasive approach in refractory out-of-hospital cardiac arrest versus conventional. And we compared invasive approach, which was intra-arrest transport under mechanical CPR, and early or immediate ECPR plus invasive investigation, mainly by coronary angio and PCI, versus standard care. So we assessed 4,345 patients within the study period, which has been 7 years, as I said, and we ultimately randomized 6% of patients and allocated them to either invasive or standard arm. What is interesting is from the baseline characteristics, if you see on the right-hand side, more than 80% were males. They had a usual profile in terms of medical history as a cardiac arrest has, but they were younger than the usual cardiac arrest populations. The age was 56 to 57 years of age. Usually it's about 65 years, so we picked up the younger patients with less comorbidities. The majority of them were resuscitated on a public place, and 60% of them had a ventricular fibrillation or shockable rhythm as a first rhythm on scene. We had a very, very high percentage of bystander CPR. As you can see, it was more than 97%, which is something we had a problem to explain to the reviewers of the journal. And you should know that in Prague, the average number of bystander CPR is over 80%, and this has been definitely a selected part of all CPRs. As you can see on the left-hand side, our randomized patients were 6% of all cardiac arrests. And this is very similar to other studies showing that somewhere between 5 and 10% of cardiac arrest cases out of hospital, are suitable for ECPR, for example, the Vienna study and other studies showing that. We had also very high percentage of telephone-assisted CPR, so dispatch-directed CPR, more than 77% in both arms. We have randomized patients after 25 minutes of cardiac arrest, so 10 minutes to reach the scene and 15 minutes of advanced cardiac life support by the EMS crew. So very similar to what I've said at the beginning, that at least 15 minutes of professional CPR should be provided to our patients. And interestingly, intermittent ROSC had a third of our patients. Concerning procedural characteristics, you can see we had a majority of our patients were really refractory cases. So 55 and 73 patients have been resuscitated for more than 45 minutes. So very long cardiac arrest, refractory to conventional CPR. In both groups, more than 4 defibrillations were provided on average. And you can also see that despite that, in both groups, quite a bit of patients reached return of spontaneous circulation on the mission, 44% in the standard group and 27% in the invasive group. Those patients who didn't reach return of spontaneous circulation in the invasive group are those patients who have been connected to ECLS. And in the standard group, there were crossovers from standard to invasive, and this is 10 patients who have been connected to ECLS who are actually crossed over from the standard to invasive. This is our results. Our study was also stopped by the DSMB because the crossed stopping rules, and we have not reached the statistically significant difference in the primary outcome of survival with CPC 1 or 2 at 180 days, but it was borderline. However, we reached a statistically significant difference in the neuro outcome after 30 days. Patients treated by ECPR and invasive approach also survived better within 180 days. And most importantly, similarly to Canada study, in the group of patients who have been resuscitated for more than 45 minutes, as you can see here on the right-hand side, there were 6 versus 20 survivors. But what you can see over here, in these 6 patients in the standard arm who survived well with a good CPC, actually 4 of them were those who were crossed over from standard to invasive. But as we had to present as an intention to treat, they were counted here, still significantly different. So basically we had 2 survivors in the standard group versus 24 survivors in the invasive group in those patients who have been resuscitated for more than 45 minutes. So if we take our results together with the arrest results, what we can say, the chance to survive cardiac arrest for more than 45 or more than 50 minutes is very low or null in patients who are being resuscitated conventionally. However, in those patients who are treated with ECPR, the survival is really reasonable and is over 20%, and this is important. The other fact that needs attention is the fact that 5 of 11 patients who have been crossed over from standard to invasive were actually patients who survived well with CPC 1 or 2. So we picked up appropriate patients where we violated the protocol to save the patients, and we saved 5 of 11 of them. So let me conclude briefly that not ECLS alone or device alone, but a comprehensive approach, including ECLS, may have an impact on logistics for out-of-hospital cardiac arrest patients and possibly for their survival. So now we have a technology. We have first randomized data showing evidence for benefit in those patients, and we still need to define really properly the patient's demographic areas, optimize logistics, and probably replicate this in a routine practice. So if I go back to our beginning, whether ECPR should become a routine for cardiac arrest, I say yes, but selectively in selective centers which have a large experience with both ECMO and cardiac arrest and cannulation during cardiac arrest. Thank you for your attention.
Can you hear me? Yes.
Yes.
First of all, let's thank you very much for sharing this impressive data, those recent data. Are there any questions from the floor? No, are there questions?
One question.
Ah,
But for the sake of time, we have to keep it short.
I have just one question. I was really impressed by the high number of bystander CPR in Prague, because that's excellent that you can achieve that. But in many regions, this is not the case. And what would then be the best way to determine actually the time of no flow in such a patient? Because that will be very important in having neurological deficit, yes or no?
Exactly. This is the major point, that the ECPR will work only on top of the very well functioning pre-hospital system, including high percentage of bystander CPR. Prague has over 80%, Scandinavian countries have over 80%, Netherlands has a very high percentage of bystander CPR. Paradoxically, Germany doesn't have so high percentage. So it's geographically related, and you just have to work on that. That's, past 10 years we have been working on that with our EMS.
Okay. I also have a short question. I'm hoping that you are keeping up the follow-up of your patients so that neurologic outcome can be published and later on, because I think we are all wondering the good survival or that you are presenting.
Yes. What I am presenting is, I'm not sure whether you understood well, is that we are presenting data after 180 days, CPC1 plus 2, so basically healthy people after half a year.
Okay, and do you have an idea of the percentage of patients that are just going back to work, doing what they did before the cardiac arrest?
It's over 80% of them.
Okay, that's very nice.
And this is a good. They do really well, and there's a limited number of patients with a bad neurological outcome. But the important message is, and we cannot go into detail, is that there is an evolution of neurological outcome within the first 2 or 3 months. So what we will hopefully show early is that if you have a cardiac arrest or ECPR study showing only 30 days of neurological outcome, this is too short, and the people evolve. And this is important to really present hard data after half a year, because this is a very resource demanding approach, and we have to be sure that we are really picking up the right patients, and the patients will return back to work or to regular life.
Yes, I totally agree. Are there other questions? Yes, there is one coming up.
No?
Yes.
Yes.
Yes, it works. It works now. Yeah. Okay.
Excuse me, do you think it could be a good idea to implement, to learn how to resuscitate people, to educate the population to do it, put it mandatory at school to learn how to do resuscitation to avoid a too long time of no flow? And we could perhaps implement it all around Europe in school.
Definitely, yes. It's an activity which is actually led by the European Resuscitation Council, and Professor Bottiger from Köln, I guess, is a major person in this. And I'm really sure that the kids, children, young adults, and everybody should be taught and should learn how to provide BLS and how to provide emergency care. And moreover, not only bystander CPR itself, but also dispatch organized CPR. It's important fact that the dispatcher actually says or directs the bystanders on scene what to do and how to resuscitate. This is of major importance. And to be honest, I think if we have more survivors will survive due or thanks to this activity, not due to ECPR, because this is a very limited number of patients who are suitable for ECPR.
Thank you.
Okay, thank you very much. I think we can close this talk and we go on to the next speaker. It's a pleasure for me to introduce you Stepan Maluniak. It's a perfusionist from Ukraine, and he will talk about the use of ECMO during myocardial revascularization in cardiac catheterization laboratory, his own experience.
Thank you for introduction. Thank you, EBCP, for invitation.
You can take off your mask. We will hear you better.
I will be glad to be here. And for next 10 minutes, I'm going to talk about our study headed by our professor Oleg Loskutov using ECMO in CAS lab during myocardial revascularization. Ich declare it no. Today, percutaneous coronary intervention is the main method of treatment acute coronary syndrome. But in some cases, especially in high-risk patients, PCI can complicate it by significant hemodynamic instability, which requires using additional methods to life support, such as intra-aortic balloon contrapulsation or extracorporeal membrane oxygenation, ECMO. But does IABP increase survival? In this prospective randomized trial for patients with acute myocardial infarction and with complicated cardiogenic shock, EABP support didn't increase 6 and 12 months survival compared with control groups. Despite earlier vascularization and optical medical therapy in both groups, mortality was still higher than 50%. In another study, moreover, the 12-month survival of patients with cardiogenic shock during PCI who had IABP was 3 times lower than of patients treated with IABP together with ECMO. Good results from using ECMO during PCI is also reported in a retrospective study from Netherlands. In this study, we arterial ECMO in PCI for ST elevation myocardial infarction had a survival to discharge rate at 67%. With good results, even patients were admitted with off-hospital cardiac arrest. That's why the objective for the study was to evaluate the efficiency of ECMO during PCI in our CAS lab. For this retrospective study included 23 patients with acute coronary syndrome who had undergone PCI with application of ECMO in our hospital during 2014-2018. Diagnosis of acute coronary syndrome was made on the basis of clinical data, ECG data, increased cardio-specific enzymes, and echocardiogram. The analysis of clinical and demographic data were performed. The average age of patient was 65 years. The main common comorbidity in this patient was arterial hypertension, and second place, chronic kidney disease. Our ECMO consideration is presented on slide. You can see. Percutaneous cannulation were performed by modified Seldinger technique under radioscopic control. At the distal end of venous cannula was located in the junction of right atrium and superior vena cava, and the distal end of arterial cannula was located in common iliac artery or distal part of abdominal aorta. In general, during ECMO, ICT levels was maintained at 65 millimeters, 180 to 120 seconds. The mean arterial pressure was maintained at level 65 millimeter hydrardium. The weaning from ECMO was considered when patient was hemodynamic stable. Here adequate parameters of blood gases and flow ECMO less than 1 liter per minute per square meters. As the results, all patients were divided into groups: survival, 10 cases, and non-survival, 13 cases. It's interesting that in survival groups, ECMO before PCI was more often used against non-survival group. 90% against 8%. The groups were similar for weight, age, number of affected coronary arteries, TIMI flow before PCI, left ventricle ejection fraction. The most infarct-associated artery in both groups was anterior intraventricular branch of left coronary artery. It should be noted that in non-survival, right coronary artery was significantly more likely to be infarct-associated than in survival patient. After analysis of comorbidity, it was found that the presence of chronic renal disease, right coronary artery occlusion, and diabetes mellitus were independent predictors of mortality. We also saw that thrombus extraction procedure was more performed more often in non-survival patients. In this group, the no reflow phenomenon was also recorded in a larger patient of cases. Only 1 of 10 survivals needed cardiopulmonary resuscitation, while in all non-survival patients CPR was performed. In addition, as you can see from the bar chart, we can see that non-survival patients showed a higher incidence of complication compared with survival patients. So ischemia of lower extremities 1.5 times and bleeding in twice were more often in non-survival group compared with survival. The average time of patient connection to ECMO during the procedure from the moment to calls ECMO team was 36 minutes. We also found that the duration of ECMO in non-survival group was 4 times longer than in survival. The total survival on ECMO, 61.8%, 30-day survival, 43.5%. In conclusion, I would like to say that application of ECMO before PCI in high-risk patients show good results of short-term survival. ECMO-supported PCI is a good therapeutic alternative for high-risk patients with severe coronary artery disease. Further research with a larger number of patients, prospective randomized trial, is needed to fully assess its efficiency. Thank you for attention.
Thank you very much for coming all the way from Ukraine to bring us your nice work. Are there any questions from the audience? Glenn, I would like to look at you. Dr. Papalardo, you're a cardiologist. Would you like to ask him something in this setting?
Yeah. So, identifying those patients who have high-risk PCI is very difficult because it's a mixture of clinical presentation, myocardium at risk, and coronary anatomy. So how do you proceed usually in selecting candidates for ECMO in your center?
In these cases, it was a patient with cardiogenic shock, and before PCI, we don't know about coronary artery anatomy in this patient. And we application ECMO in these cases. Thank you for the question.
Any more questions? Yes, we have another question for you.
Maybe a quick one. Did you do echo before you went for VA ECMO? Because in retrospect, this might be a nice population for protected PCI with an impeller device, especially if the RV is still working. Or
thank you for questions, but we don't use impeller in our clinics, so we can't compare this patient because we don't use impeller for during PCI.
Do you perform an echography, an ultrasound?
Yes, of course.
We have another question over there.
Did you leave your patient on ECMO after successful PCI, and if yes, how long?
The average time was 17 hours. Average time when we leave patient after successful PCI.
Which criteria did you use to discharge patient from
discharge
ECMO?
So we don't analyze this data, only duration, but if I remember, it's maybe 10 days at hospital admitted.
Thank you very much. I think no more questions.
Okay,
Thank you
thank you.
again. We will now break for lunch. The inner self is also important, so I know we're over time, but I think we can grant you 45 minutes if that's okay. And after the lunch, we'll come back here, and then we have the talks of the industry. So I would like to encourage all of you to come and listen to them. Have a nice lunch, and please interact, enjoy the live presence of everybody.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your invitation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new Rotaflow 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features that concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarms algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption metrics. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MEC procedures with an even more efficient centrifugal pump. The HL40 is the centerpiece of Gettinger's surgical perfusion portfolio. Alongside the HCU40 heater cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator family. The first commercial units of our new HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 system. I now leave the place to the video presentation, and I thank you for your attention.
We hope you enjoyed learning about our HL40 heart-lung machine. Getting Out also offers modular tubing packs, providing a flexible approach with different table, machine, and accessory modules. This allows a perfusionist to choose a safe and reliable setup that's always available off the shelf. Modular tubing packs are available in Germany, Switzerland, and Austria, with other European market launches to follow this year and through 2022. I'd now like to present our next exciting product, the Rotaflow 2 system. This is a successor to our legendary Rotaflow centrifugal pump console. We have redesigned some major features to make ECMO easier and safer. This includes a new touchscreen with user guidance, a new holder design for improved intra-hospital transport, new battery management, and a new flow bubble sensor. We completed a successful limited market release in 5 German hospitals over the summer. All 5 centers were overall satisfied with the Rotaflow 2 system, with the new features very well received. Rotaflow 2 is now available in Europe, with more markets to follow soon. Now please enjoy a short video presentation on Getinge's newest ECMO product.
ECoPEaT is a new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated into the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
At Terumo Cardiovascular, we deliver trusted technology and clinical solutions focused on patient safety and high-quality care. We are continually investing in the future to help save one more life today and every day. Terumo has numerous best-in-class and unique technologies which are always evolving to meet patient needs. As technologies transform into new products, new goals appear. Continuous product improvement to create groundbreaking medical devices drives Terumo forward. Terumo Cardiovascular has led the way in oxygenator innovation and quality for more than 30 years and was the first and still is the only company to manufacture its own hollow fibre. Our Our unique approach to a wide range of oxygenators helps perfusionists to meet each patient's oxygenation and blood management needs more precisely. Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 millilitres, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 millilitres, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions. Smaller, slighter patients can have surgery with an oxygenator that best fits their unique metabolic needs. The increased blood flow rate available with the 3,000 milliliter hard shell reservoir expands the use of a smaller oxygenator to more patients. Listen now to what perfusionists are saying about the Capiox FX Advanced Oxygenator.
So the FX line of oxygenators has the most efficient gas exchange of any oxygenator that I've used in my practice. It also has a low pressure job. And then the safety of the integrated arterial line filter is what we really appreciate. Terumo's really taken the customer feedback and made small changes to design that have helped to improve the functionality.
The Capiox FX05 oxygenator is the world's first pediatric oxygenator with an integrated arterial filter. It offers low prime volume and high performance for the smallest patients. Terumo's lowest prime oxygenator has been priming volume of 43 millilitres and a maximum blood flow of 1.5 litres per minute. The Capiox FX05 oxygenator is ideal for neonatal babies and infants. Here are the experiences of perfusionists working with FX05 in their daily practice.
Capiox FX05's low priming volume and overall design address a variety of issues and concerns been our oxygenator of choice for the last 11 years.
Choose the oxygenator that expands your options and advances patient outcomes. Choose the Capiox FX Advanced Oxygenator. At Terumo, our technology is rooted in our unchanging mission to contribute to society through healthcare by responding, optimizing, and innovating. Everything we do at Terumo connects to medical settings and patients globally. We care about the right solution for every patient. It's all about you. Contact your Terumo sales representative for a demonstration or visit terumo-europe.com for more information.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your invitation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new Rotaflow 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features but concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarms algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption metrics. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MAC procedures with an even more efficient centrifugal pump. The HL40 is the centerpiece of Gettinger's surgical perfusion portfolio. Alongside the HCU40 heater-cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator family. The first commercial units of our new HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 system. I now leave the place to the video presentation, and I thank you for your attention.
We hope you enjoyed learning about our HL40 heart lung machine. Getinga also offers modular tubing packs, providing a flexible approach with different table, machine, and accessory modules. This allows a perfusionist to choose a safe and reliable setup that's always available off the shelf. Modular tubing packs are available in Germany, Switzerland, and Austria, with other European market launches to follow this year and through 2022. I'd now like to present our next exciting product, the Rotaflow 2 system. This is a successor to our legendary Rotaflow centrifugal pump console. We have redesigned some major features to make ECMO easier and safer. This includes a new touchscreen with user guidance, a new holder design for improved intra-hospital transport, new battery management, and a new flow bubble sensor. We completed a successful limited market release in 5 German hospitals over the summer. All 5 centers were overall satisfied with the Rotaflow 2 system, with the new features very well received. Rotaflow 2 is now available in Europe, with more markets to follow soon. Now please enjoy a short video presentation on Getinga's newest ECMO product.
ECoPEaT is a new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to Connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
At Terumo Cardiovascular, we deliver trusted technology and clinical solutions focused on patient safety and high-quality care. We are continually investing in the future to help save one more life today and every day. Terumo has numerous best-in-class and unique technologies which are always evolving to meet patient needs. As technologies transform into new products, new goals appear. Continuous product improvement to create groundbreaking medical devices drives Terumo forward. Terumo Cardiovascular has led the way in oxygenator innovation and quality for more than 30 years and was the first, and still is the only company, to manufacture its own hollow fibre. Our unique approach to a wide range of oxygenators helps perfusionists to meet each patient's oxygenation and blood management needs more precisely. Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 millilitres, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 millilitres, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions.
B-Captor is the new, ready-to-go inline blood.
Okay, good afternoon everyone, and welcome after a very nice meal, a little bit short I think. Welcome to the very first Pecha Kucha session, which we have put into the program to make a commitment to our sponsors. This is a short session where our sponsors will have a few minutes to discuss some new products, some new insights from inside the company. And this is really important for them because it also has been a very difficult year for the partners from the industry during the COVID period, I think. So we thought it was very important for them to give them this opportunity. But also I really want to stress that they are very important for us. Without them, we would not be here, and the conference and the education for the perfusionists would never be possible. So I really want to underscore that. So, to begin with, we have several sponsors who are going to talk a few minutes. Our platinum sponsor, Medtronic, is the first one. And it's Jesse Wouters, who is a former colleague of mine from the Belgian perfusionists. And Jesse, it's actually a surprise for me what you are going to talk about. I don't know the topic. But you will get 20 slides of 20 seconds normally. But we will not be that strict. So, Jesse, floor is yours.
So, hi everybody, thanks for the invitation. And it is indeed a little bit a surprise. So my name again is Jesse Wouters. I'm Medtronic's Training and Education Manager for the Extracorporeal Therapies Division. I'm responsible for the EMEA region. This is the small agenda that I have prepared for you guys, so because I only have 8 minutes. But first, I'd like to share the objective of this presentation. So basically, I'm not going to focus too much on specific products, but I really want to focus on Medtronic's dedication to the cardiac surgery community, and to be more precise, to the perfusion community. And I'm going to explain you that by showing how we've grown over the years by launching innovative products, but also I'm going to take the opportunity to focus on our dedication and innovation in training and education as well. So Medtronic's presence in the Cardiac Surgery Society is stronger than ever. To be more precise, also in the Perfusion Society, our presence is stronger than before. Everybody is aware of the very strict medical device regulations which are in place, and well, the MDR is really demanding reinvestment in recertification, retesting, sharing more information about post-market clinical information and stuff like that. So, well, the fiscal impact is a bit unavoidable. And what we experience is that some companies are cutting, therefore, some products out of their portfolio and focus on specific areas of expertise. With Medtronic, we remain 100% committed to keeping our product portfolio intact. In this slide, I just want to show you our rich history of innovation. So, as you can see, in the last decade, we have launched a bunch of innovative products. In 2017, we had the Quantum Heart Lung Machine. 2019, we had the Autolog IQ, our transfusion system, together with Crescent and the Nautilus ECMO oxygenator. 2020, we had the Quantum Heater Cooler. We also have the Nautilus Smart ECMO module, and then also Biomedicus life support cannulas. And this is not the end. We keep on innovating, and I will show you that later on in the presentation. So, thanks to all these innovations over the last couple of years, we now have a big product portfolio standing here, consisting out of 5 big product lines. We have the cardiopulmonary product line, which consists basically all the components that are in the custom tubing packs. We have a big cannula portfolio. In the perfusion system, we are exclusive distributors of the Quantum Heart Lung Machine and the Quantum Heater Cooler. We have a blood management line, and recently we also have ECLS solutions available. Within Medtronic, we are continuously working together with our partners in healthcare to provide and to shape comprehensive solutions, which ultimately lead to better, or should lead to better patient outcomes. And for example, we have been paying a lot of attention to the global outbreak of Mycobacterium chimera infections. And together with our healthcare partners, we found an answer to this infection risk of both our patient and the surgical teams. And the answer, for example, is this quantum heater cooler technology, where we don't use any water, but we use a non-toxic glycol-based solution, together with single-use heat exchangers. Also, the fluid which is circulating in the quantum heater cooler unit takes place in a closed and sealed space. And also the big cooling fans, which are normally used to increase the efficacy of the radiator to dissipate the heat produced through water cooling, have been eliminated in this quantum thermal technology. And they have, well, the heat in this heater cooler unit is absorbed by a phase change material, which serves as a cold energy storage. As mentioned before, innovation is not stopping, and we're still paying a lot of attention to good heparin management. For example, we're very busy with the next generation of hemostasis management system that will replace our legacy systems like ACT Plus and HMS Plus, which comes together with a bunch of new features like an increased shelf life on cartridges. We will reduce the blood sample volume again. It will have platform expandability features and much more. All right. Also, I want to take the opportunity for the last couple of slides to focus on training and education, because training and education within Medtronic is very important, and we are basically, T&E is basically in support of the 5 product lines that I have presented to you. Well, the last year and a half, due to the pandemic, we have worked very hard in creating this dedicated customer training brochure. And all the trainings that you see here, they are done completely remotely for now, but they will be done on site again when we step in 2022. Also very important is to mention that we keep a good interactivity, because also in training and education, we use a lot of innovative technologies like virtual reality, live streaming, meeting and doing product discussions in a virtual environment that we created, which I'm going to present to you in the last slide. We also recently created and launched an ECT website where everything related to our training offers can be found, and also the customer brochure from the previous slide can be downloaded on that website. And in this movie, I'm just going to show you, and this is my last slide, I'm just going to show you all the innovative technologies that we use in training and education. So for example, we have found a way to do all our experience again in a wet lab situation. So everything is being done live, but in a virtual world. All the measurements live. They are based on measurements that I filmed before COVID hit us. In this example, you see the live stream. So from PowerPoint presentations in Zoom, we can easily switch over to multiple camera setups in an operation theater. So this is being done in the hospital in Bern, in Switzerland. And we also have a 4th camera, which is the flexible one. So the team can switch over to audio inside the operation theater. So the surgeon or the anesthetist or the perfusionist can discuss what's happening. We have created 2 VR product trainings, and they have been recently launched. One focused on the Odlock IQ, which you see here, and one on the quantum heater cooler. And this is the VR environment that we have created, and you see a bunch of avatars from people all over the globe meeting each other in that area. You see me as well with the blonde hair, and we're discussing and building up together a circuit. So this is the future in T&E. And the last thing that I want to show you, I'm already busy with a new project, which is augmented reality. So we go a step further, and we're gonna do the training in virtual reality, but then on a real demo unit, which you can see here. So very important messages with all these innovative technologies. We don't want to go away from hands-on training, because that's the golden standard. But within Medtronic, we strongly believe that by combining innovative technologies like you've just seen, that this even better fits the training needs of you guys. So thank you for your attention.
Thank you, Jesse, for this very nice presentation, and I should say that I really liked you with the blonde hair. Now again, many thanks to Medtronic for their support, and now I would like to announce Emiliano Bonnetti. He's a representative of, or a managing director, I think, from Livanova. Maybe you can correct me, Emiliano.
Marketing director is
Marketing,
fine.
okay, sorry.
Thank you, Cornel.
Yes.
So good afternoon, everyone. And it's really nice and beautiful to be back again in real life and not on team meeting that we had absolutely nothing the last 18 months. So today I'm going to speak about one product, which is the recent innovation that we launched during the pandemic period, which is ECoPEaT, and it's the new ready-to-go inline blood gas monitoring system. And here we go. And I'm gonna quickly cover on the clinical background, and I'm gonna give you a product information overview, so how it's look like, and then I'm gonna end up with the clinical experience that the RB group, in particular in the Catarina Hospital, conducted on the clinical validation and testing of this device. So starting from the clinical background, we all know that during cardiopulmonary bypass, when we are replacing the function of the heart and the lung, it's very important to keep monitoring of the parameter of the patient. On the venous line, we identify the hematocrit, the hemoglobin, the venous saturation, the temperature, and as well on the arterial line, there are very important parameters that needs to be measured. The gold standard and the clinical background says that there are machines that are normally in the lab department within the hospital that are absolutely precise, very accurate, but unfortunately they are offline device, and there is the so-called blind period in which from the OR you have to take a sample and go physically in a different room to get this measurement done. And that's why we and also other companies actually developed the inline blood gas monitoring to give the possibility to the perfusion to have a continuous measurement of parameter. And normally these devices are composed by a sensing technology on the venous line and another one on the arterial line to get the continuous and inline monitoring of the parameter. In this environment, we launched and we developed the ECoPEaT, which is integrated. It's integrated into our HLM equipment. So you see here that it's fitting on the S5. It appears up on the display of the S5. It's automatically transferring the data into our data management system, which is connected. It has a couple of sensors, one for the arterial and one for the venous, and it has a disposable, which is a cuvette, and we're going to see later on, that can be integrated into the perfusion tubing system. So we see here that we have our venous sensor. It's based on optical technology for the venous and the arterial one. We have a mass-mounted holder, and it's very important to remind that you don't have to change this holder for different sizes. One size fits all. And the sensor module, which is the hardware, can be really squeezed into the EP pack of our HLM, so you do not have any additional box or additional things that you have to mount on your HLM, and everything will pop up automatically on one of the screen of the S5. On the disposable side, we have full range on the venous side, half inch, 3/8 and 4¼ inch, and also on the arterial side we have the 3/8 and the 1/4 inch that are, let's say, the most widely used. From a graphical user interface, you see here how it looks like. It's really appearing up on the one of the display of the S5, and you can have measurement of the venous saturation, of the hematocrit, of the temperature, venous and arterial, as well as of the PO2. But the key element of the ECoPEaT is the fact that it's ready to go, and it's really ready to go technology, meaning that you do not need calibration, meaning that you can switch on the machine and the device is absolutely already up and running, and it's ready to give you accurate and reliable measurement. It saves your time, it saves cost also from a calibration standpoint, and we did this clinical verification together with the RB group, as I said, at the Catarina Hospital. And the study that they conducted is really to measure the accuracy of the ECoPEaT in comparison with the gold standard laboratory blood gas analyzers. And so we compared the ECoPEaT data on the parameters that you see here, so that are one that the ECoPEaT is measuring, with the same variable with other devices that are available on the market according to the procedure that is reported in the relative and respective instruction for use. So a study of total 40 patients has been conducted, and samples were taken and, let's say, measured against the ABL90 Flex, which is the lab gas analyzer that has been used as a reference, as a comparison value. And everything has been then compared to the different technologies. So, as I said, the BCAPTA and then other two devices available on the market. We did also a calibration, and as I said, they respected the procedure that was reported in the instruction for use, so the calibration for the CDI 500, and BCAPTA and Spectrum Medical M4 do not require calibration prior to measurement. The thing that I would like to mention is the fact that the threshold and the range of allowance was reported according to the clinical laboratory improvement amendments, which has been, let's say, considered as the reference coming from the US government. The indication that defines a threshold, so a range in which you can tolerate the value as acceptance in terms of deviations versus the absolute measurement, which is the one that has been done with the laboratory blood gas analyzer. So in the end, the result demonstrated the fact that pre-alignment means pre-calibration and post-alignment means after calibration. The BCAPTA demonstrated a very limited deviation in terms of variation versus the absolute measurement that was the one that I mentioned before, and everything has been reported under the threshold before the calibration and after the calibration as well, meaning that we can conclude that the BCAPTA is in perfect agreement with laboratory measurement for hemoglobin and hematocrit. BCAPTA is also in good agreement with laboratory PaO2 and SVO2 measurement, and it has been, let's say, confirmed that we consider that our BCAPTA operates within the CLIA guidelines prior to alignment. And this is the final message that I wanted to give you, because there are many devices on the market, but we really made the choice to have something that has a very simple, I would say, ease of use and saving your time by removing this calibration phase. That was all, Cornel, from our side.
Thank you, Emiliano.
And, thank you again for the time and the occasion to present.
No, we should thank you for your support to the conference and for your very nice presentation.
Okay.
I think a lot of people are looking forward to be using this system. So
yeah,
thank you.
You're welcome.
Our next speaker is Andreas Becker, who is representing the company of Terumo.
So thank you very much for the invitation, and let me start in saying that 2021 is a very special year, not only because the European Board is celebrating a great anniversary, and congratulations from my side, it's a great achievement. Also Terumo is celebrating a big anniversary. Actually, we are turning 100 years this year. And this gives me a great opportunity to look back to our history. Today it will be mainly the oxygenator history, but also to look into the future and speculate what the future may bring. When Terumo was founded, it was actually not a cardiovascular company. Our founder, Dr. Kitasato, was a bacteriologist and quite open-minded and international at his time. He studied in Berlin under Robert Koch. And the first commercial product that Terumo was bringing to the market was a clinical thermometer. Also, the company name Terumo derives from the German pronunciation thermometer. And today, as you can see, to honor Dr. Kitasato's work and lifetime achievement, he is even depicted on the Japanese 1,000 yen banknote. Our oxygenator history started almost 40 years ago when we introduced the world's first hollow fiber oxygenator. And since then, several milestone and groundbreaking developments have been made, like the first oxygenator with fully integrated arterial filter, the first pediatric oxygenator with integrated arterial filter, and recently the smallest full adult size oxygenator. Terumo is actually the only oxygenator manufacturer to produce their own hollow fiber. This gives us the opportunity to control the process from raw material to the finished product, and it also gives us the opportunity to modify, constantly optimize, and change the hollow fiber. I mentioned already that we are pioneering with integrated filter technology. Our fully integrated filter is placed together with the oxygenator hollow fiber within the same housing, and this allows us to reduce both the priming volume of the product as well as the foreign surface area. The integrated filter does also not depend on a purge line, so when removing air we are not generating any shunted blood flow that is eventually then lost from the main blood flow. So when developing oxygenators, we always had a strong focus on the smallest and most vulnerable patients. Today, our smallest oxygenator, the Capiox FX05, is the leading product in the pediatric segment, has a priming volume of just 43 milliliters and can run up to 1.5 liters of blood flow, making it really ideal for neonates and infants. Also in the adult segment, we use different oxygenator sizes, among which the Capiox FX15 is an oxygenator for large pediatric patients and small adults. And it's the most powerful and at the same time the smallest oxygenator in its class. Using the FX15 allows you to utilize a low prime oxygenator for a broader range of patients. And the benefit is that transfusion requirements can be reduced, and also the risks we all know that are associated with blood transfusion. Recently we have launched our latest development, the NX19. This is a full-size adult oxygenator. And with this product, for the first time, we are using a modified hollow fiber, which is a smaller diameter fiber that allows to further reduce priming volume and at the same time to make the products even more powerful. And this is currently the latest development that we use to address the primary risk of cardiopulmonary bypass, such as the hemodilution, such as inflammation, or also gaseous microemboli. So our aim always is to link oxygenator performance directly to improved patient outcome. And already coming to the end of this short presentation, the question is, what can we expect in future? Certainly, I think everybody expects that cardiopulmonary bypass will become even less invasive. We can expect components to be further minimized, to become even smaller, also more powerful at the same time. We see already now heart-lung machines start getting auto-regulated to support perfusionists in setting optimal flow and also gas transfer parameters. And certainly Terumo will also stay dedicated to the cardiovascular space, and I hope we are going to innovate for at least another 100 years so that we can continue to follow our mission to help save one more life today and every day. Thank you very much.
Thank you, Mr. Becker, and this was actually right on time, 6 minutes. Congratulations, it's not easy to do that. Thank you for the presentation, and thanks to Terumo for your support. So next we will have Dr. Matej Spasic. I hope I'm pronouncing this right. Please correct me if I'm not. And she is representing the company of Cytosorbents.
Thank you. Hello, everybody. Just one moment. Okay. So, hello once again. It gives me immense pleasure to speak here today before you. I'm Dr. Marijana Matej-Spasic, Senior Medical Manager at Cytosorbents Europe. And allow me to tell you about cytosorb therapy and its role in cardiac surgery. Imagine the following scenario. You're on call. It's late at night. An extensive anterior MI patient, unsuitable for PCI, is coming for the emergency cabbage. On top of that, this patient is preloaded with ticagrelor in the ambulance. You realize there's a long and high-risk surgery ahead of you. Moreover, you fear of postoperative bleeding. What if you're called back in the morning for re-exploration? Well, there's actually something you can do about it. Observational studies have shown that cytosorb used for intraoperative antithrombotic removal significantly reduced overall procedure duration, volume of chest tube drainage, transfusion of red blood cells and platelets, rethoracotomy rate, and length of ICU and hospital stay. Furthermore, the potential of cost reduction has been acknowledged by UK NICE MedTech Innovation Briefing earlier this year. They state that removal of ticagrelor using cytosorb is less costly and more effective than standard care of people under ticagrelor therapy requiring emergency cardiac surgery. Cytosorb adsorber is approved for the removal of ticagrelor and rivaroxaban during cardiac pulmonary bypass surgery in order to help reduce bleeding complications. Its integration into the CPB circuit, as you see here, is easy, safe, and doesn't affect your standard operating room practice. Besides ticagrelor and rivaroxaban, cytosorb is intended to be used for the removal of cytokines, bilirubin, and myoglobin, excessive levels of those. Hence, it has found the clinical use in various critical conditions such as septic or vasoplegic shock, dysregulated inflammatory response of any origin, liver failure, rhabdomyolysis, COVID-19. Clinical studies have shown that cytosorb, when used as intended, can help to rapidly stabilize hemodynamics, reduce vasopressor needs, decrease levels of inflammatory mediators, and even reduce mortality in refractory septic shock patients with acute kidney injury requiring continuous renal replacement therapy. Frequent clinical situations in which cytosorb is used in cardiac surgery setting are typically complex interventions with long CPB times, such as combined and redo procedures, then acute or active infective endocarditis-related valve surgery, aortic surgery, heart transplant, and more. Thank you for the opportunity to present cytosorb therapy. And if you want to learn more about how you might protect or even improve your surgical results with cytosorb, please visit our stand. We will be happy to show you both practical considerations and clinical evidence concerning our product. Welcome.
Thank you a lot. Thank you, Doctor, for your presentation. And I'm really surprised that there is one company that really cares about the night thrust of the perfusionist who is on call. So, very good job. Next one is Mr. Tassi. He's representing the company of Eurosets.
Good afternoon, everybody, and thank you very much first to the board for this opportunity. So it's pretty nice that we are celebrating, as Eurosets this year, the 30 years of innovation, and you as EBCP here together, we will celebrate the 30 years as well. So let's start with a short recap from the last time we met. And as you may remember, I was presenting our new solution for extracorporeal life support, the ECMO Life, that is the most gentle, safe, and versatile solution for ECMO and ECLS. It features state-of-the-art technology for optimal biocompatibility, in particular thanks to the magnetic levitation pump technology that guarantees optimal flow dynamics, that reduces blood stagnation areas with minimal friction and shear stress. Besides, the circuit is validated 14 days with our coating that is phosphorylcholine. We define it as safe, so designed for optimal patient safety. First of all, we are using a non-invasive sensoring system with 10 parameters continuously monitored. We have an integrated real backup system, and we can have an auxiliary external battery for extra procedural time in case of emergency during the transfer. Versatile is a portable system already validated for ambulance and within end of the years even for the helicopter and aircraft. We have a different circuit optimized for ECMO and even for ventricular assisted support. The last but not the least was very important for us this year because we received from Frost & Sullivan an award related to the ECMO Life, saying that is the new product innovation in the ECMO industry. Another important celebration for us is, as you can imagine, we were launching the ECMO Life in the peak of the COVID-19 pandemic. It was end of summer last year, and right now we are happy to celebrate here altogether 1,000 patients treated with the ECMO Life. Another new product that we are launching now is a new closed system that is a flexible, safe, and simple solution for the closed system. In particular, it features a unique range of volume to address volume changes or even different clinical practices with the lowest minimum volume in the market. In case we work at 5 liters per minute is 250, and the highest maximum volume capacity is 2 liters per minute. It comes with a dedicated squeezer to help better volume management, especially during the weaning phase. In terms of gas microemboli reduction, the laboratory data, the preliminary laboratory data, shows that we can remove at 8 liters per minute 99.95% of gas microemboli, and it raises up to 99.99% at 2.5 liters, obviously fully coated with phosphorylcholine. Everything is pre-connected, so it's 3-in-1, the plate, the bag, and the oxygenator. And as a final message, since every life matters, I think that everybody agrees here that we have to continue to work together constantly and strongly with the physician, clinician, and the company, the industry, because we have, let me say, a common goal that is to contribute as much as we can to the better patient outcomes. Thank you.
Thank you, Mr. Tassi. And this was the final presentation of this session, but I should mention that we have one sponsor left, but unfortunately, they could not be here because of the company's policy due to the COVID regulations. And that is the company of Göttingen. They are also one of our platinum sponsors, so I would really like to mention that too, that they also keep on supporting the EBCP and the education for the European perfusionists. Also tomorrow, every participant of the ECoPEaT is also able to visit our sponsors in the exhibition hall of the EX conference. So remember, tomorrow you're also welcome there. So thank you everybody for your attention. We will have a short coffee break now, and we will see you soon in half an hour. Thank you.
Dovrebbe funzionare ora. Eccolo. Dison.
We will remember that in the future.
Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 millilitres, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 millilitres, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions. Smaller, slighter patients can have surgery with an oxygenator that best fits their unique metabolic needs. The increased blood flow rate available with the 3,000 milliliter hard shell reservoir expands the use of a smaller oxygenator to more patients. Listen now to what perfusionists are saying about the Capiox FX Advanced Oxygenator.
So the FX line of oxygenators has the most efficient gas exchange of any oxygenator that I've used in my practice. It also has a low pressure top, and then the safety of the integrated arterial line filter is what we really appreciate. Terumo's really taken the customer feedback and made small changes to design that have helped to improve the functionality.
The Capiox FX05 oxygenator is the world's first pediatric oxygenator with an integrated arterial filter. It offers low prime volume and high performance for the smallest patients. Terumo's lowest prime oxygenator has been priming volume of 43 millilitres and a maximum blood flow of 1.5 litres per minute. The Capiox FX05 oxygenator is ideal for neonatal babies and infants. Here are the experiences of perfusionists working with FX05 in their daily practice.
Capiox FX05's low priming volume and overall design address a variety of issues and concerns been our oxygenator of choice for the last 11 years.
Choose the oxygenator that expands your options and advances patient outcomes. Choose the Capiox FX Advanced Oxygenator. At Terumo, Our technology is rooted in our unchanging mission to contribute to society through healthcare by responding, optimizing, and innovating. Everything we do at Terumo connects to medical settings and patients globally.
We care about the right solution for every patient. It's all about you. Contact your Terumo sales representative for a demonstration or visit terumo-europe.com for more information.
ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to Connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
Hello everyone and welcome to Gettinger's EBCP session.
Tu vois, là, je suis sur celle de 15h-17h. Non, à 15, ici à 14h30.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your invitation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new Rotaflow 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features that concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarm algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption metrics. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MAC procedures with an even more efficient centrifugal pump. The HL40 is the centerpiece of Gettinger's surgical perfusion portfolio. Alongside the HCU 40 heater cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator family. The first commercial units of our new HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 system. I now leave the place to the video presentation, and I thank you for your attention.
hope you enjoyed learning about our HL40 heart lung machine. Getinga also offers modular tubing packs, providing a flexible approach with different table, machine, and accessory modules. This allows a perfusionist to choose a safe and reliable setup that's always available off the shelf. Modular tubing packs are available in Germany, Switzerland, and Austria, with other European market launches to follow this year and through 2022. I'd now like to present our next exciting product, the Rotaflow 2 system. This is a successor to our legendary Rotaflow centrifugal pump console. We have redesigned some major features to make ECMO easier and safer. This includes a new touchscreen with user guidance, a new holder design for improved intra-hospital transport, new battery management, and a new flow bubble sensor. We completed a successful limited market release in 5 German hospitals over the summer. All 5 centers were overall satisfied with the Rotaflow 2 system, with the new features very well received. Rotaflow 2 is now available in Europe, with more markets to follow soon. Now please enjoy a short video presentation on Getinga's newest ECMO product.
At Terumo Cardiovascular, we deliver trusted technology and clinical solutions focused on patient safety and high-quality care. We are continually investing in the future to help save one more life today and every day. Terumo has numerous best-in-class and unique technologies which are always evolving to meet patient needs. As technologies transform into new products, new goals appear. Continuous product improvement to create groundbreaking medical devices drives Terumo forward. Terumo Cardiovascular has led the way in oxygenator innovation and quality for more than 30 years and was the first and still is the only company to manufacture its own hollow fibre. Our unique approach to a wide range of oxygenators helps perfusionists to meet each patient's oxygenation and blood management needs more precisely. Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 millilitres, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 millilitres, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions. Smaller, slighter patients can have surgery with an oxygenator that best fits their unique metabolic needs. The increased blood flow rate available with the 3,000 milliliter hard shell reservoir expands the use of a smaller oxygenator to more patients. Listen now to what perfusionists are saying about the Capiox FX Advanced Oxygenator.
So the FX line of oxygenators has the most efficient gas exchange of any oxygenator that I've used in my practice. It also has a low pressure job. And then the safety of the integrated arterial line filter is what we really appreciate. Terumo's really taken the customer feedback and made small changes to design that have helped to improve the functionality.
The Capiox FX05 oxygenator is the world's first pediatric oxygenator with an integrated arterial filter. It offers low prime volume and high performance for the smallest patients. Terumo's lowest prime oxygenator has been priming volume of 43 millilitres and a maximum blood flow of 1.5 litres per minute. The Capiox FX05 oxygenator is ideal for neonatal babies and infants. Here are the experiences of perfusionists working with FX05 in their daily practice.
Capiox FX05's low priming volume and overall design address a variety of issues and concerns been our oxygenator of choice for the last 11 years.
Choose the oxygenator that expands your options and advances patient outcomes. Choose the Capiox FX Advanced Oxygenator. At Terumo, our technology is rooted in our unchanging mission to contribute to society through healthcare by responding, optimizing, and innovating. Everything we do at Terumo connects to medical settings and patients globally. We care about the right solution for every patient. It's all about you. Contact your Terumo sales representative for a demonstration or visit terumo-europe.com for more information.
ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to Connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.
Hello everyone and welcome to Gettinger's EBCP session at this 35th annual EX meeting. And first of all, thank you for your participation. We would like today to highlight our two latest products in the cardiothoracic field with our new HL40 heart and lung machine and our latest generation of ECMO console, the new ECoPEaT 2. In the HL40 video, you will first discover the description of the HL40 features to allow you to see in brief description the main features, but concentrate the best of the technology to meet the needs of perfusionists in terms of safety, flexibility, adaptability, and ease of use. Most of these features are completely new and were developed after discussion and work with perfusionists to define priorities. Thanks to the technology, the HL40 achieves a high level of safety with, among other things, a specific alarm algorithm, alarm messages with guidance, and an automated perfusion calculator mode for the BMI, BSA, index flow, and consumption metrics. The new Rotaflow 2 system drive is now available with the HL40 to perform ECC and MEC procedures with an even more efficient centrifugal effect. The HL40 is the centerpiece of Gettinger's surgical perfusion portfolio. Alongside the HTU 40 liter cooler unit, the MetaVision perfusion, our patient data management system, and of course our Quadrox I oxygenator panel. The first commercial units of our new HL40 console have been shipped to customers in Europe and in South Africa. And to date, more than 1,000 procedures have already been performed with the HL40 systems. I now leave the place to the video presentation, and I thank you for your attention.
Just say Mr. Condello. Not artificial interference.
Okay, welcome back everyone. Maybe you want to take a seat. This is the last scientific session before the grand finale, which will be given by Carol. I'm happy to see you all here. My name is Alexander Warber. I was the chairman of the EBCP for some years, and I would like to kick off this last session. And the first speaker is Mr. Condello from Bari in Italy. He's a perfusionist there, and he will give the first presentation. Maybe I started for you.
Hi, good afternoon, everyone. I started with this presentation, management algorithms and artificial intelligence system for cardiopulmonary bypass. And this is my disclosure. And when I start with my first letter to editor 3 years ago, I say that technology has made a great progress, and it will be possible to replace the Formula One car driver with an autopilot. This does not happen because we believe that sensitivity and interpretation of the human mind and body is superior in terms of performance and balance about time. It's possible to think the same for the extracorporeal circulation and the perfusionist. An artificial intelligence could be support and not of substitution of the sensibility of mind. Maybe one day it will be possible, but not yet. In this Ishikawa diagram, I identify in the past the 4 macro areas of cardiopulmonary bypass: safety, practice, understanding and interpretation of parameter, the management, and these 4 macro areas give in the time the goal of cardiopulmonary bypass. This is another letter about the metabolic management. Today, the problem of artificial intelligence is not in the safety system, but the extracorporeal circulation in the last decade, reducing the accident that have an institution of algorithms, for example, for high pressure excursion, alarm of levels, bubble sensor. We had many weak artificial intelligence for the safety. This situation resulted in a wide variability in the management, for example, of indexed oxygen delivery. We have high variability, for example, through increase a cardiac index, or we use a transfusion of blood product, or use ultrafiltration or diuresis. These different pathways have different clinical impact. And the integration of this algorithm in a metabolic system in relation to pathway and analysis could give the appropriate path. And the concept that we favor and propose is a color code, for example, for the parameter to be improved red, and the secondary parameter to improved orange, and the final corrective solution was green. This is an interesting graph about the oxygen delivery. Simplify that we can see 3 different parameters for the group, and we found that the patients had a cardiac index, high cardiac index in relation to a low level of hemoglobin, or low cardiac index in relation to high level of hemoglobin. But in this graph, we don't see the VCO2 parameter, don't see the temperature parameter, don't see the mean arterial pressure. And this is a problem in the management of goal-directed perfusion. This is a very interesting graph that do my friends Marco Moscarelli. And each parameter have an interaction with other parameter. And if I modify a parameter during cardiopulmonary bypass, the extracorporeal circulation, I modify this parameter in relation to the other. Today, we observe a great enthusiasm in the biomedical company for the concept of the translation, modulation, and automatization. In particular, we observe that now it's possible to have blood-gas tests during cardiopulmonary bypass. In the future perspective, the possibility to choose the threshold to cause, for example, the PO2, and the algorithm, the workstation, give the possibility to modulate the flow of the air and the VO2 during the procedure in relation to the pump flow and the external administration of carbon dioxide. For example, for estimation formula of the real and the relative VCO2 value. And this is another example, futuristic example of translation and modulation for the vacuum-assisted venous drainage. Today, the other problem that we have when we manage vacuum in extracorporeal circulation, we don't have a real parameter And the algorithm gives the possibility to manage this parameter in relation to the venous return excursion or the flow variation of the pump and aspirators. In this context, I write a review about the management algorithm with my colleague in my center. And we observed that have two differences of artificial intelligence, the strong and the weak artificial intelligence. The strong replace totally the human mind. The weak artificial intelligence support the people to the best choice. And the application of this concept is not only for the clinical practice, but is for the training, the safety, and the translation and the comprehension of the parameter during the procedures. It's possible to realize many algorithms different for every center, for every tradition, for the guideline. And the problem is this algorithm had an impact, a positive impact in the clinical practice. This is, for example, an example of support of the management of central venous pressure in the establishment of cardiopulmonary bypass. We observe is most commonly when we start with CPB procedure, we had a high central venous pressure, the echocardiographic patterns, for example, with the stretch of the cavity, and is a good step to identify the passage for the solution. The first is the calibration of the zero pressure. The second is the reposition of the venous cannula with transesophageal echocardiography, or sides of cannula mismatch, and in this context, the possibility of use of the vacuum-assisted venous drainage. This is an example of algorithm solution. We had many other algorithms. For example, the other problem today is the venous return. I think for understanding the goal-directed perfusion, I give to young perfusionists to manage for the best way the recording, the monitoring of the venous return, give the possibility to produce a good indexed oxygen delivery. And we observe that have many ways for measurement the venous return during the procedure. For example, the density, the mass, or calculation with a flow meter in the inlet of venous return and in the outlet of venous return. This is another example of algorithm solution when we had in arterial line a low saturation of oxygen, and this is a frequently problem in my jobs. I had 3 times the problem of the connection of the gas line. This is important for a young perfusionist to understand the correct way for give the solution during this problem. The first is the cooling of the patients, for example, the control of gas line connection from gas blender to the oxygenator, or from the oxygen and the air line connection to the gas blender. And this is an example of safety in the training and the clinical practice. This is another algorithm for mean arterial pressure. Today is different. The management of mean arterial pressure depends of the anesthesiologist, depends of the situation, depends of the typology of patients, and perfusionists give vasoconstriction drugs frequently in many centers, but probably the increased the cardiac index is the first solution, or probably the reduce of intracavitary aspiration is the second solution. If is not enough, give the vasoconstriction, but not the vasoconstriction is the first solution. This is for algorithms for the goal-directed perfusion. In this algorithm, we don't see the DO2 VCO2 ratio that I product in other algorithms. That we can see that I identify a good level of venous reservoir of 800 milliliter, depends of the models of reservoir that we use. And this is a suggested action for insufficiently oxygen delivery during the procedure. We observed that in red had a critical parameter, and in green color the machine talk with the perfusionist and suggest the potential solution to improve the goal-directed perfusion. This is another aspect that is crucial, the management of hypothermia during cardiopulmonary bypass, from normothermia to hypothermia, when, where, and how, for a good hematocrits, a good hemoglobin level during the procedure. The use of a machine that suggests the correct hemoglobin during the procedure, during a deep hypothermic arrest, prevent the problem of microcirculation of viscosity. It is very important for the students use the simulator for understanding this parameter. In conclusion, the advantages of artificial intelligence applied to metabolic management during extracorporeal circulation give the possibility to integrate and calculate the variable. I think that this vision is a difficult vision today, but I think is a good compromise, is a good proposal for the future. Do algorithms for training for the students and for support the perfusionist in the critical situation during cardiopulmonary bypass. Thank you so much for your attention.
After the session, after the three speakers. Thank you very much. I think we take questions after all presentations have been given. So maybe Gudrun, you would like to present the second.
Yes, it's a great pleasure to introduce the next speaker, Dr. Pepper Strate from the University Hospital in Ghent in Belgium, and she's going to talk about e-learning for ECMO training.
Hello, good afternoon. It's a pleasure for me to be here, and I'm going to try to introduce you in the world of e-learning in ECMO. The literature has been exploding the last 2 years, and we all know the reason, I think. Learning from a distance has been, for some people, the rule. And so the literature I've used to make these slides, it's mostly literature from undergraduate nursing schools, from graduate nursing schools that go for specializations. And in surgery, there is also a lot being investigated. So I have no disclosures to make. First, I want to orientate, in fact, the digital learning, electronic learning, and mobile learning. E-learning, in fact, is all the learning supported with digital electronic tools and media. M-learning, easy to remember, it's everything you do by your mobile phone using your Wi-Fi network. And then the digital learning is actually any type of learning that uses technology or ICT to present, in fact, what you want to teach more clearly. So the digital learning facilitates the learning by using ICT. It's also important that the content is of high quality, and what is very special in that your instruction can be very personalized, because the trainee can choose his own trajectory that he wants to follow, and the teacher can make differentiations for every part of the group. There are four fundamental perspectives of e-learning that need to be delivered in higher educational institutions. So they are important in terms of making a good e-learning platform. So the cognitive perspective is the one that embraces everything about how you can remember things, knowledge, and how the brain works. The emotional perspective is mostly about your motivation, why you want to learn something, and how you feel during the learning moment. Are you are you happy because you can learn something? Are you fearing that it will be too difficult? Or are you in the end very proud that you succeeded the learning process? The behavioral perspective is you need to think before starting a platform, what do I want the learners to do in the future? Which changes are important? And then in the end, the contextual perspective, it's very important that you think the process that we want to learn or the facts that we want to learn or in a situational are very important in that situation or need to be implemented with other parts of the team. So the team members, their role, that's very important. So e-learning is actually, as I said before, any platform available on the internet. And as you know, sometimes it's more closed and it's intranet because you need a login or you need to be on a certain server. You need technical skills, not only the learner, but also the one who is making the e-learning. So you should really think before starting about the technical skills that are needed. What you can find in literature that you see that in Africa, where the distance is very long, and then during COVID they could not go to the university anymore, that they had problems with setting up a Wi-Fi network, things like that. So that is what I mean with also technical skills. Your e-learning is mainly focused on knowledge. It's also the content will be fixed. You think about your content and then it's fixed, but you can make updates during the months after, the year after. The user can choose his own speed and his own sequence. So how fast he will take it. Is he redoing parts? Is he taking a break? Things like that. Mostly there is no direct contact, but I will come back on that because also e-learning can be, as we do now, that I just talk to you, and that in the other parts of Europe they can follow this session. So mostly there is no direct contact in time and in space. Very important is that the learner is responsible for his own growth, so his own learning curve, but also the teacher, he will need to learn about the e-learning platform and how we can ameliorate the platform and what he's giving. And actually, it should be with a focus on innovation. So, what are the advantages? That it's very accessible, it's easy to use, that it's cost effective, but with that I have a small remark. If you remember, I said you have to have the technical skills. Learning that sometimes for a teaching team, for educators, can be so time consuming that actually the win is at the very end after several years, because when you are used to just teach like you were doing, just you in front of a room of 20 learners, and then you should switch or make the switch and make an e-learning platform, it can be so time consuming that actually the cost effectiveness is on the long term. As I said before, user satisfaction, your own pace, and you can choose wherever you sit, in your living room, in your garden. There's an unlimited number of participants, so the room where you teach is not longer a limiting factor for the participants, and you can go across borders. So what are the needs? To start with, you need a very good learning management platform. It has to be a software that does not stop during setting up the e-learning. It has to be a platform that can carry a lot of megabytes, gigabytes, and if you use the movies, it has to be a strong working memory. You need to have a content management. So if you work on the e-learning with different teachers, you have to talk with each other, and you should control if your subjects are not too related or you're not giving the same topic, because it's very important that if you update, that your colleague is not updating the same thing. So there should be one manager who has an overview over the management. You can deliver the content synchronously or asynchronously. With synchronously, it's just like I'm telling you here, I'm talking here to you, and it's synchronously to you and to the people who are following this session in other countries. Asynchronously is just that I make a course and everybody starts a course at the moment he wants. Very important is that you need an assessment. In every learning process, at one moment you need to be tested. Somebody has to tell you, okay, you passed, you know what you need to know, and somebody has to give you feedback. For e-learning, mostly what they do is they create a test, and when you have succeeded that test about one part of the e-learning, then you can proceed to the next part. Also very important is that you set the level that you need to have on that test before you can pass the test. If you have done the test on an e-learning platform, you want feedback. If you don't understand, you should have a way that you can write an email or just give or ask feedback to the teacher. I really do not understand. Why is it that my answer is not correct? Things like that. And the feedback has to come very soon back. So not after weeks, because mostly the learners are there sitting at their desk and they want to proceed and they have a question and really they want the feedback fast. Very important. If you want the learner to continue, give your feedback very quickly. Also, for an e-learning, if you want to differentiate, it can be very important that you can scope on a particular element. So a thing that you think this is basic, but not for everybody, and then you can put in a hyperlink underneath it, and so then you have a mini training on one topic. So that's also a need for e-learning, because otherwise when you are teaching in a normal classroom, a learner will ask you something, I'm not following, can you explain that? So you have to make a backup plan for that. A good e-learning is time-spaced education. With that, I want to say, so not one training session. So it has to be spaced over a year so that you can repeat some topics and also that you can go back to the e-learning or retest some things. Yes, and then you need standards because it all has to have a good look to make it attractive. So nowadays, a lot of education uses blended learning, and blended learning is just a mixture of online teaching and in-person teaching. So an online portion effectively replaces some of the face-to-face contact time rather than supplementing it. So you are not repeating what you studied before. So you can have a discussion about it, you can have questions about it, but you're not giving the same topics face-to-face. And flipped classroom is actually a type of blended learning. So as you can see on the graph, in traditional schools, you first get a lecture and then you go home and you have your homework. In a flipped classroom, there you first have your lecture at your computer at home. You think about it, maybe you have questions about it, and then you go to the classroom and there you can discuss with your peers the problems you see when you do not agree, and you can ask your teacher for more explanations. And also what will happen is, if needed, you had your learning, your basic learning at home, and the practical sessions will be with your group and with your peers. So what are the barriers to develop and to implement the e-learning then for any training? The technical skills deficit of educators, because it can take a long time to set it up. And with that goes the inadequate time to devote to the development and the amelioration of the electronic tool. You can imagine that you have your electronic tool and that you want that your colleagues test it. They give you feedback, but then you have to retake it to make it better, and that can be so time-consuming that really finishing the e-learning is hard. You need an infrastructure and technology, so actually what you need is a good ITer in your team who can help you with your hardware, with your software, with downloading things that can work or cannot work. What you find also in literature, that when a school or an institution thinks from now on we go for blended learning, and that topic, and that topic should be done by e-learning, and you give no training to the teachers, that they will never start, because they think, as I work now is good, so I won't do it. And also, a negative attitude can come up when you receive harsh criticism, when the process seems so difficult, so time-consuming. So it's very important that if you are not the one who decided to start off with an e-learning, that the institution or the one who is just above you, who wants to do you, that to start up with e-learning, that he explains you very well why it could be good for your learners or your students to start off. So now, before we go then to e-learning in ECMO, what are conclusions mostly made in the end of the articles? So you should always use your technology in an appropriate context. So focus on your learning objectives, like what should they understand, what should they know. Also for psychomotor learning objectives, what do I want them be explained? And also for the affective learning objective, like attitudes, can I put it in an e-learning or not? So, but your content should be fixed before you start. So you should include assessments and feedbacks, but be careful, because there is a large gap between the literature evaluating the impact of technology on long-term retention of the learners, and in the end, the changes in the patient outcomes. There you cannot find anything about that. So in our hospital, by creating the e-learning platform, what we want one for the beginning and for the more experienced ECMO providers. So both of them should be happy what they find on the platform. So you need good fundamentals, and you should have places where you can fresh up already known knowledge. So how will you make your fixed content? For that, we use the modified Delphi questionnaire. The modified Delphi questionnaire we sent out to ECMO experts, and we used actually the ELSO lists of topics for the ECMO curriculum. The topics we already give during our ECMO training and the simulation program. We also used the e-learning from the colleagues of Leiden. Our daily ECMO management, when a question pops up, the technical skills we want our team members to perform, and the wanted attitudes. And then we made the whole list with statements. Just to know, a modified Delphi questionnaire comes from actually a board like yours, for example, perfusionist, and if you want to make a statement of, for example, basic things to do to start up in your operating room, what should be checked, and if you have no literature, imagine that, about that, you can start a Delphi questionnaire. You just ask as experts, what do you think you should start with when you enter the operating room? When you use a modified Delphi questionnaire, there is already literature about it, but you want to test if it's up to date. Just for the statistics, you will see that a statement will be considered as a key competency when at least 80% of the experts agreed. So a rating on a Likert scale of 4 on 5 or 5 or 5 on 5. And then for internal consistency and for internal consistency, the Cronbach alpha score was calculated. And for reliability index and inter-rater consistency, we used the intra-class correlation. Who were the experts? It were experts working in a hospital with at least 20 ECMOs a year. It were physicians, nurses, and perfusionists. We also had surgeons who helped us, but that are surgeons who are really also dedicated to or very interested in the ICU and the critical care patients. In the first round, we sent out 56 possible essential ECMO skills, and then we got the scales back, but also more comments about the statements where we should change the statement or other statements or other skills that were needed in the list of essential ECMO skills. So in the first round, you see we send out 56 possible essential ECMO skills, and after having the feedback, in the second round, we had 60 possible ECMO essential skills. And then, as you can see here, so there were topics on knowledge, on technical skills and attitudes. For the first round, for knowledge, we had a good consensus. Almost 91% we had consensus, but for technical skills, only the half of all the skills that we thought were essential we had a consensus on, and for attitudes it was 75%. So we changed, and for example, for the technical skills, we changed really who should do the skill. So in the beginning, we stated every ECMO team member should know how to change or should be able to change an oxygenator or a circuit. And then after the comments of the experts, it was changed in every perfusionist of an ECMO team should know how to change the oxygenator or the circuit. And actually, what came out was that the quality of your perfusionist is actually very important, because almost every technical skill was then given as a task to the perfusionist. So in the end, the Delphi questionnaire ended with 53 essential ECMO skills, 34 knowledge topics, 10 technical skills, and 9 attitudes. For the cognitive learning, so the knowledge, we think actually about it and what can we give on an e-learning, but what is best in ECMO is that you use the flipped classroom, so you can give your basics with an e-learning, but then the best is that you have problem solving in a team. You can have case discussions and conversations about specific practices that you do in your hospital. So if you think then about your knowledge, we all studied in books in the past. Books are really out of date, so now we study more on computers and we have data on computers. So that's how e-learning goes. You can implement a little test, you can add a little quiz, but actually it can be, and in surgery you see it already happening, it can go to serious gaming. So that's not a real game, but it's really you're in a virtual reality world and there everything happens as you decide, and then you see the consequences of your things you're doing. For psychomotor and more concrete, the technical skills, it's more difficult in e-learning because what has been seen for medical students, that if you give an explanation by e-learning, for example, drawing blood in a patient, you can do it, you can repeat it, but actually it's not as good as doing that and just repeating it. So what can be done is that you make a movie as a preparation. So best is then step by step, so that you can pause the movie and that you have an explanation about every step. But then after that theory, that you go to hands-on session, or for ECMO then to water drills, and that there is really an instructor coaching you very closely. Very closely, because when the group is too big for technical skills, you will lose your efficiency. So in simulations, you can use then, after having your basics, your theory, for cannulations, for emergencies, and also for your daily management. When you go then to more the behavioral skills, like for surgeons, we want to take them that role for the nurse at the bedside. What do we want her to do to prepare a patient for ECMO? So you can tell in your e-learning what you want people to do, but actually you have to train it. So for e-learning, it's very little that you can do for behavioral skills. So you can give the basics, but then you have to train it in simulations. And the communication is very crucial. If you want people to talk to you in an emergency situation in a certain way, you have to train it. I think in our hospital, we could say that sometimes we had some problems with emergency situations and surgeons who didn't know very well the nurses in the ICU. And then we got back on that. And what we do now is really train our younger nurses how to talk to the surgeon if she does not like the communication. Things like that. But it's really a team education. Everybody has his role to play, and it's an interprofessional learning curve that you need. For attitude, it's a bit the same as behavioral problems that you need to solve. So you have to start with an appreciation for the role of every team member. You should start with shared decision-making. Everybody is equal in saying something about that simulated patient at the moment, but everybody is equal in popping up solutions for a certain problem. You should go over case-based discussions that go back to reality, so not too far from reality. If you just had a difficult case in the ICU with a patient, take just that case in the simulations, because you will see the emotions pop up, and at that moment you want them to have a certain attitude. So for that attitude, you can give an orientation in the e-learning, you practice in simulation, but very important, reflect on clinical experience in daily settings, because the emotions pop up then. So,
many more slides?
That's the last one.
Okay.
To prevent knowledge and skill decay, you should know that after 6 months, you lose everything of a training if you do not repeat it. So what can be a solution, and what they sometimes offer, is that you can give just-in-time training. So, for example, if a nurse needs to do a night shift, that she can go through a specific technical skill with her teacher before she will work in a night shift. Yeah, these were my conclusions, but I think I...
Okay. Thank you, Dr. Peperstra, for this very nice exposure about e-learning. I noticed that there is a small mistake in the abstract book. Normally, now Mr. Parasido is coming, and he has been mentioned as an abstract speaker, but that's not quite correct. He's an invited speaker. So I prefer to have him to go first, if it's okay with you, Professor Waba? Yeah. Mr. Parasido, he's a perfusionist in France. Actually, he's Italian, so he knows a little bit about the situation in different countries in Europe, and that's also his topic of today. Thank you.
Good afternoon, everyone, and thank you for invitation. I will try to talk about the situation of perfusionists in Europe. The interprofessional collaboration between clinical perfusionists and the professional figures that surround them is an integral part of the treatment of patients with heart problems, and I ask you, a constant in all European countries, or at least they should be the case. To date, within the various European countries, there is no uniformity regarding the law to recognize clinical perfusion, there is no training standard, and nor a unit in the task described. The gap within each nation and between nations exists, and in some cases is very obviously. We have a need to fill by the common recommendation regarding the required knowledge, special tasks, and responsibility of the clinical perfusion. The use of extracorporeal circulation in cardiosurgical patients has been studied for 60 years in the context of the complex treatment process of this patient, preoperative, intraoperative, and postoperative sub-process required interdisciplinary cooperation, each one with their respective area of expertise. The cooperation and competence of all personnel involved in cardiac surgery and adequate infrastructure are essential for maintaining the quality of treatment and the result. The definition of the responsibility and the quality standard, as well as the definition of the knowledge and the task required for the professional group concerned, are important steps in the context in order to implement a sharing of legal responsibility are the basis of a clear division of tasks and the principle of trust. The clinical perfusionist represents a medical profession that is not limited to the practice of medicine. There are also areas of engineering responsibility, and the profession is characterized by the close interweaving of knowledge and basic technical and engineering skill with particularly medical knowledge. For this reason, it is indispensable. The clinical perfusionist is also responsible for the technical support, maintenance, and operationality safety of the Employed Medical Device Act and other potentially statutory regulations. In all of these activities, the clinical perfusionist is guided by internal and international guidelines. But due to the lack of legal regularization at the European level, the European Board of Cardiovascular Perfusion has set the goal of defining the competence level of clinical perfusionists with regard to structured training of establishment the corresponding required uniformly throughout Europe. Unfortunately, however, there are completely different situations between European states. In fact, each state and each nation association of perfusionists must adhere to different legal norms and training paths for different perfusionists. This often involves a lack of legal and economic recognition of the profession with a conquest of the motion. Taking a tour of Europe, I will try to illustrate difference and similarity in different countries, starting with the countries that I know better. In France, where the function of perfusionist is currently performed by the nurse, concretely the formation is with their pairs directly on the field thanks to a companionship of several months. There is a common initial training in the country, have 2 university degrees, but is not required to practice extracorporeal circulation. have a lack of specific profession at legislative level. In the absence of a license as provided by law, clinical perfusionists are currently allowed to engage in the practice of medicine by delegation. A 2-year master degree program in perfusion was established in September 2020, and the program is accessible to nurse, MD, and pharmacist. In Italy, existing a specific degree course was accessed irregularly through the prerequisite high school diploma. For the course admission, the student will need to take a competitive entrance examination, and the course consists of 3 years of theoretical courses and an internship. During the internship, students rotation in cardiothoracic surgery, cardiology, interventional cardiology, ICU, echocardiography, and cardiac electrophysiology. To carry out an extracorporeal circulation to provide a technical support in minimal invasive heart surgery, technical support for pacemaker therapy, to ECMO, to echocardiography, and to carry out all measurements for processing and retransfusion of autologous blood components, to assume the responsibility for tasks in organ transplantation, and to contribute to the research project. In Germany, to date, the German federal law does not recognize the clinical perfusion as a qualified occupation with a specific certification. Nationwide, no education standard exists as an entry requirement to professional perform clinical perfusion, nor are there any duties and tasks described. In the absence of a license as provided by law, clinical perfusionists are currently allowed to engage in the practice of medicine by delegation. In Netherlands, have a theoretical perfusion training in Leiden. Every perfusion student has a medical or biological background before starting the perfusion training, and every cardiothoracic surgery hospital sends the perfusionist in training to this theoretical training 1 week a month for 3-4 years. The education in Leiden is a master's degree. In Austria, 3 sources of profession. The education required employment in one of the 9-year center in Austria and lasts 18 months, and with a diploma examination at the Ministry of Health. And in Austria, there is no special school or academy for perfusionist training. It takes place practically by perfusionists in the context of an employment relationship with the patient. In Croatia, have a school or academy for perfusionists and work 1 year in first shift period in which learn the practical part while the theoretical part is self-taught. In Belgium, 2 training schools, but the absence of the perfusionist function, the perfusionists are just given a classification nurse, and the situation is very similar to France. In Great Britain and in Ireland, all trainee perfusionists attend the University of Bristol to take the 2 years master course in the perfusionist science. Training also included carrying out a minimum of 150 perfusion cases under supervision in the hospital where the trainee is employed. The Society of Perfusion set the standard of conduct competence of the profession and also ensure that the standard of registered practicing clinical perfusionists are maintained. Thanks to this, there are guidance on good practice in the provision of clinical perfusion service and the administration of drug by clinical perfusionists, and are clarified their role and responsibility. In Spain, in general, the perfusionist is not recognized by the health ministry. In Andalusia and Catalonia are the only area which the perfusion is more protected with a title called Advanced Clinical Practice. There is an official master by Barcelona University, but it's not required for practicing the perfusionist profession. In most cases, perfusionists are responsible for technical issues concerning the extracorporeal circulation, but the medication level Spanish law does allow us to prescribe. And in Portugal, have to take a course of clinical physiology 4 years and 2 years of practical training. In conclusion, the obvious difference in terms of training, legislature, and recognition mean that there are different status in Europe with different tasks and responsibility. There should be reform implemented to create a uniform level of education and responsibility in the different states throughout the Europe. The purpose of this reform will lead to unification of tasks, compensation, and most importantly, responsibility within the operation room. And I leave with this question: is the word of European perfusion ready for this? Thank you so much.
Thank you very much for a very comprehensive presentation. We'll come to the questions after the next talk by Professor Waber, who is a surgeon in Trondheim, and Alexander was a chair of EBCP for the last 10 years. And he's going to talk about European perfusion guidelines. Where are we now? Thank you very much.
Thank you, Gudrun. Welcome everybody once again, and especially everybody who is listening to us at home. I would like to talk to you about the perfusion guidelines and where are we now. This is the title of the guidelines that were published in 2019. It was guidelines presented by 3 organizations, EACTS, EACTA, which today is called EACTA IC, and EBCP. And 3 people were the heads of the different working groups. That was myself, Gudrun, Luc Puis, and then we had Milan Milojevic, who was a helper for the more practical things. We had a big task force which was selected by the 3 different organizations, and you can see all the names that participated in the task force. The situation was such that we worked closely together, and many of us knew each other beforehand, so it was quite easy to work together in this group. The aims of our guidelines were to produce guidelines that are comprehensive, pretty comprehensive, but there were several topics that we excluded, partially because there were other guidelines already available, for example, on temperature management. And there were other topics that we excluded because the guidelines would have been too large, with including, for example, guidelines on pediatric perfusion. The most important aim for us was to use evidence-based facts with references in the literature to give a recommendation. Of course, we didn't always have these facts, but still in the guidelines we always tried to give the reference, and we tried to show why did we decide that way. So it was not only that experts would sit down and agree, but it was a very strong focus on the scientific basis. We also agreed upon to have the European perspective in mind. Now, during the review process, people would say to us that there is no European science, so science is international. But the problem is that perfusion is practiced very differently in different countries, and we thought that it was important to produce clinical guidelines that were useful for everyone. Another important point was that we would discuss during our meetings, and we would give recommendations all together. We never had sort of a vote on any of the recommendations. We always agreed on all of them, everyone in the team. And that made the guidelines stronger, we felt. And then 3 papers were published simultaneously, and all 3 papers are the same guidelines, but they were published by the 3 different organizations in 3 different journals. One journal was the Interactive Cardiovascular and Thoracic Surgery, which is the official journal of the EBCP. Then we had one publication in European Journal of Cardiothoracic Surgery as the official journal of the EACTS, and we had a publication in the British Journal of Anesthesia, which represented the EACTA. So all three are the same contents, but it's a different first author, just showing that the task group was constructed of three different organizations. Now, as I said, we tried to have pretty comprehensive guidelines, and we had a big part on training, education, and service delivery, and of course there's not so much science on this topic, and there we had recommendations that were based on consensus between the task force members, but we had some literature also on these topics, and we included this literature. And then, as you can see, there's many points that are quite hard facts, like pumps or pump holders, safety features, heater-cooler units, and we tried to find all the literature that was available on these topics and included it in the guidelines. We also had important chapters on disposable articles like cannula, reservoirs, oxygenators, pumps, filters, and we also looked at the surface treatment in general. Of course, this is a large topic, like which materials are used and how much does coating change the behavior of these materials. We also included a number of checklists in the guidelines, and we felt that this was very important. The idea was not that everybody should use the same checklist, but it was an example of checklists, for example, checklists that should be used before weaning off bypass. And the idea was to give a sort of an example, and that every unit would design their own checklist by using our example. We also had a lot of contents referring to procedures, like is it important to flush with CO2? What is the scientific use of pulsatile and non-pulsatile flow? What are strategies for transfusion and blood products? And here we already had guidelines from the EACTS and the EACTA, which were very specific on transfusion. So we only repeated some of these issues and we referred to the other guidelines. So we didn't redo the whole process because these guidelines were pretty new. We also looked at very controversial topics like cardioplegia, and as you all know, there is enormous amounts of literature on cardioplegia, but there is still no universal agreement on how to deliver cardioplegia and which cardioplegia should be used. So we just reflected what there is of literature. There's a lot of literature on other topics, for example, lung protection, and this is also reflected in the guidelines. So these are more topics that are more related to the anesthesiologic part of doing perfusion, but we felt that that was important to add this to the guidelines. Interesting is that as I said, we had a weaning checklist and we had some comments on reperfusion, but amazingly enough, there is almost no literature on reperfusion time, and there's very little content on the use of weaning checklists. As you can see, this rounded off the guidelines that we produced, and the question is, were these guidelines well taken care of in the community? And I'll show you some results of what we know. The problem is that if we really wanted to find out what do people think about guidelines, we would have to make a big questionnaire. And then, of course, you have the problem that the ones that answer the questionnaire is a completely different group of people than the ones that don't answer the questionnaire. So it's not easy to have a questionnaire or a system to really find out what people think or whether they are using the guidelines in daily practice. But we can say that about 14,000 people looked at the guidelines that were published in the European Journal of Cardiothoracic Surgery, and about 7,000 people looked at the guidelines published in ICVTS. Unfortunately, we don't have such a statistic on the British Journal of Anesthesia. But we know that the British Journal of Anesthesia has been very well received, and you see this donut on the left-hand side. It gives an impression of how many people actually use tweets or Facebook or other ways to communicate about these guidelines. And there you can read in this section that this article is among the top 10% of all research outputs ever tracked with this system. So very well discussed and used. The same is true for the guidelines published in the European Journal of Cardiothoracic Surgery, that was also in the top 10%. And ICVTS, of course, is a smaller journal. It was in the top 25%. But that means altogether, all three articles have the same content. So that means that this is a very strong paper that many people have looked at. And then what about scientific citations? Of course, citations, that's one side. We think it's very good that people use our guidelines and say, I read it there, this is the citation, this is the standard of practice. But even more important is the daily use, the clinical use. Anyway, the guidelines are cited more than 100 times in these 2 years that they have been out, and this is quite a good figure, I think. So what about the future? The normal procedure is to revise guidelines, and the ECTS tries to have a 4-year time window to revise guidelines. Now 2 years have passed, so next year we will have to sit down again and look at these guidelines and find out, are there new publications? Do we need to change some of the chapters? And we are aware of some small issues that maybe need to be corrected. But within a year's time, we have to sit down and really sort of find out how are we going to do that. And then we will publish new revised guidelines. So what do we need to do in the meantime? Actually, we need you to give us information about how could we make guidelines in a way that it's easier for you to use in clinical practice. Do you need sort of shorter summaries of the guidelines? Are there aspects that you think are completely out of the normal practical procedure in some countries? So, for example, the issue of using filters is a very controversial issue. There are some countries that traditionally have not used filters in their perfusion circuits, and there's other countries that feel very strong about filters. So that is one of the things that we like to have feedback from the perfusion community. Because you have to remember that doing guidelines is work in progress, and that means you're never finished with guidelines. You always have to go back and start again and improve the guidelines. Thank you very much.
Thank you, Professor. Thank you, Professor, for this nice presentation. So may I invite the 4 speakers on stage for the discussion, please? So, Professor Waba, maybe I will start with the first question. You mentioned that there are no guidelines for pediatrics. Is that also the plan for the future to establish them?
Yes. What we are doing now is that we are working on a memorandum of understanding between our 3 societies, and we try to establish rules and sort of roadmap for the future, and pediatric guidelines is one of the points that we would like to address. Right now, there is one project already starting, and that is patient blood management guidelines for pediatric population. That is sort of in the starting phase, and we're hoping to really get on with that very soon.
Okay, I'm looking forward to that. So are there any questions from the audience?
I have a question for Ignacio Condello. Thank you very much for your presentation. I think artificial intelligence is something we have to keep an eye on. But should we also question then if we want to do that, and especially when you were mentioning that this is important for safety, that we are also trying to get our systems more uniform? Yeah. Because nowadays one of the issues is even if you want to use artificial intelligence, you have some issues that everyone has his own system. And to make this algorithm working well, probably uniformity will be an important issue. What's your opinion about that?
I think that this algorithm gives the opportunity to understand for the community of the perfusionists and a condivision the perspective about safety. For example, how many checklists today we use we had the guideline, yes, but every center produce your checklist. I think that the production of the algorithms in terms of safety give the opportunity to equalize the difference that today persists in the perfusion practice. This is my vision.
But can we really do that in that way? Because I'm just wondering, if you compare to dialysis environment, if you compare to some other renal or extracorporeal technologies, they have automated systems. Yeah. So it would make sense that we would have, for example, a machine which is automatically priming based on known parameters, but for that, again, you will need uniformization. So are we willing to go that step? Because artificial intelligence is one part of it. The other one, it also will ask some mental flexibility of the average perfusionist, perhaps.
Yes, it's crucial that the perfusionist the flexibility, yes. I think that it is a system that not replace the perfusionist, but the support in the best choice. This is my perspective. It's very important that you give the possibility to give to the perfusionist to do himself the question for improve the practice, the management, the safety, the metabolic way, for example. Yes.
Thank you so much.
Thank you.
Maybe I could also ask a question to Ignacio. Yeah. You're talking about artificial intelligence, but maybe I missed it. In my opinion, you just showed automatization of algorithms and digitalization of algorithms, but artificial intelligence, and as I believe it was invented, is actually improving the algorithms itself. So are we going that direction? Because that also means artificial intelligence has often been shown as the new holy grail, but as I know, artificial intelligence can also teach himself the wrong algorithm. So you need to maintain and correct the database, I think, from once in a while. Otherwise, you have the risk that it will make mistakes. And also, I think you will need a lot of data to improve the algorithm. So are we going to collect these data? And what is your opinion about it?
Yes, these are correct question and observation. It's important to collect the data, and it's important the homogeneous data. Today we had how many goal-directed perfusion? Yes, we have a number, we have a predictive way for example, for acute kidney injuries, but we have many ways for had this number. I think that this variability is a problem for the analysis. The use of and a condivision of algorithms is the first step for collect the data, and after the machine learning give the opportunity to the perfusionist to understand the potential solution. It's very complex, but I think that with the new technology, the new machine, the new devices, the translation of parameters, the continuous monitoring, this is a good way. And it is important that we condivide this vision. Okay, thank you.
I've got one more question to Ignacio as well, please. So you mentioned using AI for the security as a safety measure. You mentioned AI for using it in training of perfusionists. What about the routine use and your routine work of AI? Would it replace our thought process or decision making?
Today, in the safety, is presented the simulator, for example, Califia, and this is an optimal example of artificial intelligence for learning or reproduce the situation for adverse event during the procedure. And I think that is very useful for the students in the accident during the procedure, give the opportunity to do the best solution. Is present artificial intelligence in every day in the clinical practice in some aspects of the perfusion, but is not present in other aspects most important that had a clinical impact, in particular in a metabolic pathway and in other aspects of perfusion. But in my center, we use the simulator for improve the technical skills.
So that's for the teaching and during your day-to-day work?
Yeah.
During running a cardiopulmonary bypass?
Yes.
In theater?
Yes. Yes.
Are there questions for the second presentation? Maybe I can, yeah. Leon, please.
Yes, first of all, thank you to all the speakers for a nice presentation. I have a question for Harlinde. I really appreciate your initiative. As you know, I'm also very much involved in ECMO training. But this e-learning that you are setting up, would this be something that could be of any help outside of your hospital? I mean, is it hospital protocol oriented, or is it really the basics? Because I'm sure if people hear about this, they would like to step in. Is this possible? Could you?
So to start with, we make it in Dutch, so that there is no language difficulty. And at this moment, I think for coagulation, there could be an heparin protocol that we should stay then very general. But that part I didn't do. So the part that was already made is like the physiology, anatomy, the ultrasound, guidance function, things like that. It's very general, but it's in Dutch. So I think we can
translate.
Yeah, or remake it, because translate, can be difficult.
Okay, thank you.
I've got a question, sorry, to Herlinde as well. You talked very comprehensively about e-learning, and after the students have learned, they need to be tested as well. Do you have experience in e-testing, online practical testing, oral testing, or written tests?
In our hospital, the surgeons have a lot of experience with that. It's time-consuming because they need to ameliorate and little aspects in the questions needed to be changed. It was very good for anatomy, so pointing on, for example, for liver surgery, which part would you think of for surgery to take away, why not? And then they had to point out that artery is going there, and so things like that. And that worked very well when they needed to point out things. Then multiple choice questions worked all out also. And then for our e-learning, I have some questions, but then I was thinking that Philip was going to fill in the whole test, and then that has to be then the best score, and then we need some students with no background to do it, and then it's see what level they get, and if it's too easy, we have to make it more difficult. So the test is not done yet, because the one who is helping me is now in a long time sick period, so in hospital. So that's the reason.
Thank you.
Yes, I also have a question for you. You said that it was important to get help to organize e-learning, and obviously you had help from professionals. Would you say now that it was worth the effort, or what were the biggest advantages for you with the protocol that you have in place now?
So, for first, I didn't finish yet because my help on the technical platform, he's ill for 4 to 6 months. So normally he got back Monday, but he didn't reply my email where I asked, "Are you back?" So we will see. Alone you cannot do it, I think, because you really need a good platform and somebody who is used to change quickly things. So yeah, but we need to test it first. But alone it wasn't possible.
Very good, thank you.
Any more questions from the audience? No? I think we can conclude this session for now then. But I would like to announce our final keynote speaker, who is Carol Hamilton. She's going to talk about 30 years of EBCP. I'm really looking forward to this presentation. So Carol, I'm very glad you could do this talk, because it was a hard job to find someone who was willing to give it, so go ahead.
Well, thank you very much. I see they don't have short versions for me to talk with here, so I'm kind of hiding behind here. I hope you can hear me. I'm Carol Hamilton, and I'm originally from Canada. Did my studies in Toronto and also worked in Toronto and started in 1978. Can everybody hear me okay? And I did meet the love of my life in Canada. I was an avid windsurfer at that time, and it was a day that there was no wind. We ended up being on the beach for a little bit, changing numbers in the sand. And that's the man who I married, and then he was a nice German fellow, so that's why I find myself now in Germany working for over almost 30 years, actually. So a little bit enough about me, now the European board. Do we just go like this? Touch. So I decided to give this talk about celebrating 30 years of the European board and not perfusion in Europe, because as you see from Alexander's talk about the professions and training of perfusionists in the different countries, you really have a lot of limitations according to the language, according to how they're trained, how many people that they have, what sort of societies are there. So there are really a lot of issues. So the European Board actually was founded in 1991 by a group in the UK and also in Germany. They had also invited the American Society to help them out in this initiative, actually to unite European perfusionists. And if I look over my career of 43 years now, then I really think I wouldn't know what to do without a society, without a board, being able to have other colleagues in contact with about different issues in perfusion. So it's really important to have these societies and also our guidelines. So the representatives from the perfusion societies were invited to these meetings, and I'm not exactly sure. I joined the board in 1997, so I'm sure that there were a handful of people there on that day when they were talking about forming the European Board of Cardiovascular Perfusion. They basically wanted for equality of standards in both training and professional status. So this was the basis of the European Board. To this date, 33 years later, there's 29 member countries from the EU, and we also have 3 affiliate countries which do not belong to the EU itself, but they actually saw the potential and the benefit being part of the European board under an umbrella of the society. And you see in South Africa and Oman, the affiliates, and then the different countries that are part of the member countries. So we really did achieve a lot, getting a lot of countries. There's still some other countries coming in with their membership, but very important is that they should have also a society initiating the process for membership from the European Board. Also to this date, we have close to 3,000 ECCPs, the European Certificate of Cardiovascular Perfusion. It is an international association, and all this information is actually on the webpage itself. Basically, it's got to do with education. It's got to do with getting a certification in ECCP. And this here, these two actually give you your competence and knowledge and the qualifying certificate that you are a professional perfusionist. So actually the mission of the perfusion societies of the different AU member countries is to encourage and foster the development of the profession. And this is what it's all about. I always say it's not a job, it's a profession, and something to be really proud of. And I can really say after the 43 years that I'm really proud of the profession, what we have and where we're going and the future of it. And this you can really achieve really through education and certification. Coming up to professional recognition, we've heard a couple talks of the professional recognition from Alexandro. And this helps really to try to get some sort of legal recognition that we really need. There are only a handful of countries that really do have perfusion as a legal profession. And this is really being pursued by a lot of countries, because with this, when you do have legal profession recognition, then you can actually go a little bit higher in status, and you can actually show that you're a specialty that is really very valuable. So we see here the initiative from the EBCP, perfusion position paper in 2006, and it was actually from the European Parliament that shows that the recognition of the professional a directive, the qualifications are there. The second one you see is actually from Germany, from Adrian Bauer and other. You're never alone when you're doing these things, because it would be much too much work, as we know. So he was able to publish this paper in 2020, January, in the Interactive Journal of Cardiovascular and Thoracic Surgery, about the qualification, knowledge, tasks, and responsibilities of the clinical perfusion. And this is a real milestone for helping getting Germany as part of legal recognition. They also have 2 more university centers with bachelor and masters in perfusion now established in Germany because of this. And it's because of the help of these professionals that are getting the profession moved forward where it should really be going. So the organization of the board is basically made up of trustees, the office, and our delegates. And the delegates are a very important part, because they're the ones that maintain the communication between the European board and also their national society. Under this, we have then 3 committees, and they're the accreditation committee, certification, and scientific. Go through that. So this is the office with they also have the assistants. With this, the accreditation committee is actually setting up the essential and guidelines for training programs, almost training of the trainers, who are the people responsible for training and education in each country. The European Board does site visits and for the accreditation of training programs, which allows in the students to actually write the European Board exam to get then their certificate in perfusion. And this actually leads then to qualification recognized by the AU societies. We also have the certification committee, and they look after the exam and also regulate, of course, the academic standards of the exam. And November of every year, they do have the sitting of the exam by the students or other perfusionists that meet certain criteria to write the exam and actually have the certificate. And then the scientific committee, this is where I live here. We have, for every committee, we have a chairperson, Gudrun, the chair for scientific committee. We have the secretary, that's my job there. And also then different members that look after different parts of looking at, of providing professional services for the perfusion community, such as this meeting, such as webinars. So we all network within one another, and we help also with the standards and guidelines. As you saw from the talk from Dr. Waba, he actually is responsible also too with Le Prix. He couldn't be here at this time, for looking after the 219 guidelines, which was a lot of work. So all these committees that we have, we have a net flow within the group. There is a lot of overlap, and we do have meetings 2 times a year. And okay, with this slide here, I'll do with this one here. I just wanted this slide here will just show you that we have also the cooperation and support of the European Association of Cardiothoracic Surgery, and we also have cooperation with Euro-ELSO and also the ACTA. So you have the surgery, anesthesia, and then the ECMO program being partnering with EBCP. The 219 guidelines, as we saw from Alex, was also a very important milestone. And that came because of the fact of the support of the European board and who to contact, the people to contact regarding these guidelines. So there were a few countries which this was a very important paper to bring back home with them. We do have 2 meetings a year. And if you see here with the officers and members of committees, the delegates, all the representatives, the surgical representative, anesthesia, and Euro-ELSO, we have really over 60 people with these meetings that we network with from the different countries going over the different directives. At the very top, this is the webpage, the ebcp.au, and you can actually see information here such as writing of the exam, certification, recertification, and then the different meetings. So unfortunately, we had this COVID time, and Waldo was very lonely. You could find him anytime here. And so we had to be quite creative. What are we going to do when we can't meet personally at our meetings? And so this is here, which we have our webinars that we started once a month, alternating with either the introduction of a member country that's part of the European board, where they show about their national society, what kind of research they're doing, a little bit of information. And the alternate month is about scientific, any sort of scientific research that we would like to present, like the priming, or we will talk about ECMO as a future one. So the next webinar will be the 17th of November, and North Macedonia will actually discuss their perfusion and their perfusion society in a 1-hour session. So this is the last slide here about our ECoPEaT meeting. It's actually 21 years old. It grew from a number of 17, was the first meeting we had then 2001, where we had 17 people, and grew up to over 500, which is attended not only by perfusionists, but also attended by anesthesia and surgery. And it's really one of the best networking places that you actually will get to meet your colleagues, not only colleagues, but friends that you've made here over the years. And this is what is really, I would think, a very great accomplishment. And even today at lunchtime, we were sitting at the table and we had 8 different countries sitting talking about the same thing that we do every day, but how much we hate on-call. Of course, I don't have to do any more on-call, so it's okay. So that is the end of my talk. It's been a real pleasure to be here. And do we have Dr. Vandervelde? Is he going to end the meeting, or?
Dr. Vandervelde?
Yeah, yeah.
I'm not a doctor.
No.
I will give the closing remarks. Yeah, thank you, Carol, for this very nice presentation. Yeah, and I think there's nothing left now but to thank a few people. So for me, this was a bit of a roller coaster the last few months, organizing this conference, not knowing how many people who would be able to attend this meeting because of the COVID regulations. But I think it was very nice today, and I realized, and as Carol also mentioned, that the live conference is a big difference as compared to the many webinars we all attended the last 20 months, just because of the contact you have with the different nationalities and the discussions you can have in between sessions and also during the sessions. So I hope everybody realized that today, and we really hope to welcome you all next year. I don't know when it will be, and also the people from ECoPEAT don't know where it will be next year, but there will be a conference. I really should thank, firstly, ECoPEAT for the cooperation, for this magnificent location here in the conference room, and especially in the lunch room, where we had this magnificent view at the Mediterranean. So I know from Philip and the rest of the European board that we are really hoping to extend the cooperation with ECoPEAT in the next few years, and hopefully the next 30 years, I think. Secondly, I really have to thank all speakers from the scientific faculty, because it was not evident, it was not very easy to come here during this special period in society. So thank you all for coming. It was a really high level of scientific presentations, I think. I also want to thank Maite Mata, but I don't think she's still... Maite, there you are. Thank you very much for being our host as the chief of perfusion of the hospital in Barcelona. It was a really nice faculty dinner yesterday. I will never forget, so thank you very much. And to end especially, I really need to thank our sponsors, being Livanova, Medtronic, Getinge, Cytosorbents, Thermo, and last but not least, Eurosets. I hope I'm not forgetting anyone, but we realize that we really need you to sustain these conferences, to maintain the educational level of European perfusionists. So it's really important that we keep on supporting each other, I think, and we really hope to see you again next year at the next conference. Thank you everybody for coming. Thank you to the people at home who are missing out really interesting discussions, so maybe you should come to the conference live next year. Thank you everybody.
And sorry, I just want to add.
At Terumo
Thank you,
Cardiovascular.
Cornel. You did a great job. It was very hard, but you did great. You did fantastic.
At Terumo Cardiovascular, we deliver trusted technology and clinical solutions focused on patient safety and high-quality care. We are continually investing in the future to help save one more life today and every day. Terumo has numerous best-in-class and unique technologies which are always evolving to meet patient needs. As technologies transform into new products, new goals appear. Continuous product improvement to create groundbreaking medical devices drives Terumo forward. Terumo Cardiovascular has led the way in oxygenator innovation and quality for more than 30 years and was the first, and still is the only company, to manufacture its own hollow fibre. Our unique approach to a wide range of oxygenators helps perfusionists to meet each patient's oxygenation and blood management needs more precisely. Studies have shown that controlling hemodilution through lower prime volume circuits can result in fewer blood transfusions. That's why we offer a choice of 3 different sizes within our Capiox FX line of oxygenators. The Capiox FX Advance has been proven to advance patient outcomes. Improved flow dynamics reduces blood turbulence and enhances gaseous microemboli removal. Its elongated shape provides stable, smooth blood flow. Since its launch in 2008, the Capiox FX family of oxygenators has helped save the lives of nearly 2 million patients worldwide. Studies have shown that by reducing hemodilution with a low prime volume oxygenator by as little as 150 millilitres, there is less chance of blood transfusions and reduced risk of post-operative acute kidney injury. The Capiox FX25 Advanced Oxygenator is the perfect choice for an adult male patient. The unique design provides a full-size oxygenator with a low priming volume of 260 millilitres, and the hard shell reservoir offers a reduced minimum operating level. The Capiox FX15 Advanced Oxygenator significantly lowers prime volume for patients at risk for a higher rate of blood transfusions. Smaller, slighter patients can have surgery with an oxygenator that best fits their unique metabolic needs. The increased blood flow rate available with the 3,000 milliliter hard shell reservoir expands the use of a smaller oxygenator to more patients. Listen now to what perfusionists are saying about the Capiox FX Advanced Oxygenator.
So the FX line of oxygenators has the most efficient gas exchange of any oxygenator that I've used in my practice. It also has a low pressure job. And then the safety of the integrated arterial line filter is what we really appreciate. Terumo's really taken the customer feedback and made small changes to design that have helped to improve the functionality.
The Capiox FX05 oxygenator is the world's first pediatric oxygenator with an integrated arterial filter. It offers low prime volume and high performance for the smallest patients. Terumo's lowest prime oxygenator has been priming volume of 43 millilitres and a maximum blood flow of 1.5 litres per minute. The Capiox FX05 oxygenator is ideal for neonatal babies and infants. Here are the experiences of perfusionists working with FX05 in their daily practice.
Capiox FX05's low priming volume and overall design address a variety of issues and concerns been our oxygenator of choice for the last 11 years.
Choose the oxygenator that expands your options and advances patient outcomes. Choose the Capiox FX Advanced Oxygenator. At Terumo, our technology is rooted in our unchanging mission to contribute to society through healthcare by responding, optimizing, and innovating. Everything we do at Terumo connects to medical settings and patients globally. We care about the right solution for every patient. It's all about you. Contact your Terumo sales representative for a demonstration or visit terumo-europe.com for more information.
ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine. It is designed to easily and accurately monitor arterial and venous blood gas parameters, even in long and complex cardiopulmonary bypass procedures. The system is based on reliable optical technology and provides only measured values to guarantee accurate monitoring. Its sensors fit all disposable cuvette sizes for adult and pediatric procedures. The display is integrated in the S5 HLM, allowing the perfusionist to have all parameters in the same location. The ECoPEaT values are transferred to Connect, supporting the implementation of goal-directed perfusion therapy. ECoPEaT is the new, ready-to-go inline blood gas monitoring system integrated into the S5 heart-lung machine.